got dementia. Dementia further put them at risk of delirium in the hospital. In fact, one of those things we do in acute hospital is if a patient is coming, they've got dementia, you have to quickly optimize their care and send them back to their property. Send them back home, their familiar environment. So they just let them go back home to be seeing their familiar faces, their familiar environment, all those kind of things. So yeah. So like I mentioned, typical presentation of patients that are confused. They can be very drowsy on the ward. They can, new fatigue. They can personality changes as well. Is also another thing. And again, people can be delirious. Hello.
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 Hello. Good evening, sir. Sorry.
Hello. Oh. Sorry. I think one of the organizers was trying to, I don't know. Hello, sir. Don't know. All right, so I just crack on. So I couldn't pick. I'm sorry, I couldn't pick what you were trying to say. So so personality changes is also another thing. You can go on the ward and people can be delusional. For instance, if you go on the ward and people are delusional, they might even, like, for instance, now you can see people saying that, yeah, like the team, the medical team, you as a physio, everyone in the ward, everyone is just trying to kill them, something like that. People can be paranoid. This might be, have you had the family? But family might say, this is not them before coming to the hospital. Family might say things like that. So now we need to be able to support some of these patients. How do we support them? And again, ADL changes. You go in the ward. Now people can walk, they can mobilize, they can do their stuff. But now they are struggling. Could be because you need good cognitions to be able to mobilize. You are trying them with a frame. You are trying them with rotunda. We have had equipment training. You are trying them with rotunda or Sarah steady. You need cognitions for them to be able to follow that command, that two-stage command, that three-stage command. You need cognition to be able to articulate their stepping, all those kind of things. You need good cognitions. And again, people that are really confused, they can be really very anxious. Sometimes when you go on the ward, you might find these people in a fetal position on the bed. They are very anxious of the environment. They are very anxious. They are just fearful of everybody. So how do we support some of these people? Let's go there. Let me just accept these people. All right. So I've spoken about their common signs you can see. So common signs you can see, like I mentioned, people can struggle with concentrations, slow responses, hearing difficulties, seeing things that are unreal, like paintings that are unreal, like hallucinating, all those kind of things, visual hallucination, auditory, all those things. People can be paranoid, people can be restless, people can be agitating. People can struggle with their sleeping patterns. Sometimes you might find people sleeping too much in the day and and disturbing the ward at night. So what do we want to, when we go to the bedside, we can also ask the nurse, oh yeah, this patient, now you are seeing a confused patient. You can ask the nurse, how is their eating? And when I go to the ward, I ask the nurse, how is their eating and drinking? Are they sleeping well at night? What have they handed over? If you are saying you are a day staff, what have your colleague handed over to you? You should be able to feed those things back to me, because I know those things are also related to me. If they are not sleeping well in night, you want to also speak with the doctor. How about if you give them some melatonins or some medications that can make them sleep at night, that can regulate their, what do you call that thing, their sleeping balance, their sleep weight balance, all those kind of things. Because if people are not sleeping well, it's going to impact you as a physio. It's going to impact what you're going to be doing with the patient as a physio. So these are because we should all be caring for our patient. We have got equal duty of care to our patient. All right. So we move forward. So how do we quickly screen for delirium? This is also important that we need to talk about. I think a quick assessment, evidence-based. You might go to their bedside, do a quick 480 with them. 480 with them. You can do that. Oh, of course, results, of course, alertness, you should be able to score that. For the 4MT, ask them for their age, where they are, confirm their date of birth, all those kind of things. So ask them about How do you do the other one? Add them to do month of the year backward. I know these are things that are generally difficult. And again, patient education and all of those things need to be factored in as well. Or think about something you can ask. If I'm unable to do maybe complete 480, I can just do maybe ask people about where they are, where they think they are. It could be in your local dialect or something, where they think they are. They should be able to tell you their date of birth. They should be able to tell you maybe where they live, all those kind of things. Ask them those questions, text their cognitions. Those things are very, very important. So, all right. So CAM is also another thing here. I'm not going to discuss this one in detail because these are OT-led things, but I'm not going to discuss it because of time. It might take a little bit much of my time. These are something we want our OT to be able to do. If we, normally, what I think or what we do is if I go on the ward and I do my 480 and my patient is scoring high, let's say 4 and above, for instance, and I then need to speak with OTs. OT can call me. They can do some of this assessment like CAM. If they do CAM with them, for instance, if they score high, they might then speak with the medical team. Yeah, they speak with the medical team. Look at those things that might be making this man to be confused. Oh, is it pain? What are the teams doing regarding their pain? Is it their nutrition? They are not eating, drinking well. Is it their infection? What are the medical teams? So these things, all of this knowledge will further solidify, our role, our job role in acute hospitals, because we know what we are doing. All right. So yeah, I'm not going to talk about this diagnostic algorithm here because of time. We've got a lot of things to touch. I've just jumped that. So I have equally talked about there is a clear difference between delirium and dementia. One is acute, one is chronic, one is reversible, the other one is not reversible. We need to think about that. I will just jump that. So yeah, so what can we be doing with our patient, delirious patient on the ward, patients that are delirious? What can we be doing with them? Physio-wise, OT, small things we can be doing with them. The first thing, sometimes I just say to the nurse, the ward nurse, yeah. But sometimes, on the ward, they can be moving patient here and they are changing their bed location. And I want to say, yeah, we just keep these people where they are. You don't have to move them. Because if you move them, you could even be in the first place. Maybe their unknown environment they are might be the one causing their confusion. So if you now move that elderly patient from bed one, where they are, you carry them, you put them in another bed. What are you doing? You are further enhancing their confusion. Don't do that. You don't have to do that. It could be you now advising the family, advising your patient on oral care. If they are not on nail by mouth and they are able to drink and eat and drink, advise them, because dehydration, dehydration, it does a lot of things. Advise them to drink a lot of water, plenty of water, all those things. Yeah, it could be, yeah, promoting good sleep-wake pattern. Sometimes you might go on the ward and you see that their bed space is always darker, like it's always dark during the day. Why not getting the light on? Why not advising the nurse looking after please open the window, let the day, let everywhere be bright. Keep the day bright. And when it is, and again, tell the family member, come during the day. Keep them engaged during the day. How about that? During the night, what do you want to do? Because we want that good sleeping pattern. We want them to be active during the day, and at night, let them rest at night. You don't want somebody to keep sleeping during the day. That's not what we want here. All right. It could be you prompting the family. It could be you prompting the nurse in charge to be able to facilitate some of those things. And again, physio-wise, what do you want to do? Do you want to keep them in bed? No, we need to define strategies to get them out of bed, to get people moving. It could be your movement that will facilitate their constipation they have. It could be your movement now that they are moving, they are more active on the ward. It could be because of that their cognitions will get better. So we need to start moving them. We need to start moving them on the ward. And again, how about you now moving them out of that ward? Let's say, for instance, now people are being paranoid, they are being delusional, they just think everyone on the ward is trying to harm them or something. Yeah, have you had that conversation with that consultant in charge? If mental health team can come around to see them, to have some, to have their input as well. It could be you just getting them on wheelchair, with them out, get them to the garden, those beautiful garden we've got in our hospitals, get them to have fresh airs, get their family member to be there, get their family member to engage them in their normal life activities. How about orientations? Orientating them where they are, and with their date of birth, their family, this is their son, this is their orientation goes a lot. Our OTs, have they gone to the ward? Have they done like kind of orientation board? They should have orientation board. The ward staff can keep changing that date. Orientation board might contain your date of birth, the month, the year, or depending on your patient, the patient you are dealing with. Their familiar things. You can have family members to bring their familiar things to the ward, so that in order to regain their cognitions. The reality here is, if the cognition does not get better, it's going to impact their physical health. It's going to impact their medical care. And again, they can even die. A lot of people are dying because of these confusions, because of new confusion, that maybe the medical team they are struggling to map them out, or maybe the physio team or OT team are not supporting them well with it. And it's going to impact all other parts of their care. All right. So again, so there are a lot of things we can do. Asking family members to be coming around, not this one that family are trying to approach or are trying to get in touch with their patient, with their friend or something, and now people are shouting them, get out, you don't have to be here. No. That is when you can even say to the family member, they need to be doing that regular visit to the ward. That is when the family, they need to be seeing their patient the most. They need to be coming around. They need to be having that, because I am as a physio, you as a doctor, you as a nurse, you might not be able to engage them actively where they, like in their normal day-to-day activities. So it is family member that knows these people. So they were able to engage them, all of those things. So that is, those are some of those things we can be doing with our hands. So Miss Petit Joy, can you open your mic?
All right, thank you, sir. Good evening, sir.
Yes, ma'am.
Some people just join on YouTube. So we're thinking maybe if you are able to reverse a little bit. So those that just join on YouTube will be able to catch up with the lecture, sir.
Okay, yeah. I will just, yeah. Thank you very much for that. Thanks a lot. Yeah. Yeah, let me just quickly brief. So what we've been talking about here is some of the barriers we can encounter working with patients in acute hospitals. So we have talk about pain, and what we mentioned in pain is that can you please, it's a blessing, please, can you please mute yourself? Please, can you mute yourself, please?
What's going on? Some people.
What do we do now? All right. So what we've been talking about is about what we talked about previously was about pain, and I mentioned that when it comes to pain management, not, oh my God.
Blessing Akinlowa or what? Please kindly mute yourself.
How do we mute her now? I don't know.
Let the host mute her. The host can mute her.
And time is running. Admin, please, can you just mute Pretty Blessing, please? All right, thank you very much for that. Thanks for that. Yeah, so what we spoke about pain is just pain. We are not the champion when it comes to pain, because patients in acute hospitals, pain can be of different origins. It could be attachment related. It could be because of their procedure they've had. It could be anything. So think about what you need to be doing with your patient. Do you need to be empathetic with them? Do you need to break the task down for them to be able to engage with you? Do you need to use the power of MDT? Have you had that pain conversations with that doctor to be able to prescribe some strong analgesic? Have you spoken with the nursing staff to be able to give them that PRMP medication, 20 minutes, half an hour before you go in to see them? And again, you can also find You can also find some, what do you call it now? Some attachment that can also aid in pain delivery, like PCA. I showed us that thing. And again, when you also go to their bedside, patient might be on epidural infusions. Patient might be on what do you call it? They can be on epidural. They can have a nerve block. All of these things can also affect their sympathetic responses. This can impact on their blood pressure, their heart rate. And again, so if your patient is on all of those things, check their bedside ups. When you see them up, check their blood pressure, check their heart rate, monitor their distance. And again, aside from that, before you even start to do stuff, you've got good reasons to be checking their sensations. Check their sensations in their lower leg. Check their strength in the lower leg before you crack on. These are all we've said so far about pain. So you are not the chicken champ because your TENS, your infrared, all of those things, unfortunately, they won't be able to help this patient. And again, regarding MSK patient can be anywhere. A patient might be on renal, for instance, now they've got chronic back pain. Now they need their on dialysis, they are on dialysis. So, and again, patient might tracheostomy patients on head and neck, on ENT ward, they might have chronic back pain. So think about all of these things. Some of your guys might not really, so MSK again does not really fit in well, like they can be anywhere in the hospital. So, and again, remember what you are treating in acute hospitals is just your acute concern. So tie everything to functions, tie everything to ADLs, and support them with your outpatient referral if there is need for them to. So you can do whatever things you want to be doing with them at the outpatient facilities, if that makes sense. Because your goal is getting people out of hospitals safely, get them to manage when they get back home. And again, if there is need for you to follow up, you can follow up. That's all we said so far because of time. So now, we have spoken about delirium as another limitation for us as a physio. As delirium, we should, when in acute hospital, when you go to their bedside, screen for their delirium, screen their cognition. Quick 480 is something you might consider doing as well. Because of some of our patient background, it might be difficult, but you might want to think about questions that might be able to text if they have good understanding of where they are, what have brought them to the hospital, the day, the month, or depending on your patient's their background, their educational background. And again, try to work with the family members, not just getting social histories, like not just getting physical part of your social history, get good histories around their cognitions. How did they behave normally? How are they normally oriented? In terms of memory, are they fine? In terms of behaviors, get those things so that you'll be able to correlate with your patients, their patient current presentations, you're able to correlate the two together and make your inference as well. And again, when it comes to cognitions, our OTs, they might be needing to have a lot of trainings on how to support patients with delirium. And again, they should also be giving trainings to MDT on the ward. This is one of their big roles in acute hospitals, big roles. So it's not something we want to be joking. And again, delirium, like I mentioned, if care is not taken, we might struggle to optimize our patients functional wise. The medical team might also struggle with them to optimize them medical wise. And before you know, that might even be the reason for their death. So we need to be screening for cognition. So asking family members, regular visit on the ward, paying attention, regular orientations, clock our ward. We need, like, you can have family to come to the hospital with their family photos, things like that, work clock. These are ways we can support people cognition. And because of, and again, if their cognition start getting better, what do you do? Physio will get them out of bed, we tie it to functions, and that is it. So I have talked about a whole lot of things that can also, lead to cognitions being breaking down, like pain, infections, all of those things. Blood-wise as well, checking bloods and all of those things. So again, working with patients with delirium, and I've also talked about the difference between delirium and dementia briefly. Then again, working with these people can be really, really very challenging. So we must be able to know what kind of command do we need, like what kind of verbal prompting do we need to be giving to these people? Yeah, you might be needing 1-stage command, 2-stage command. 1 stage just up, stand, step, right. It could be as simple as that. And it could be you, maybe you, now they are not able to follow instruction. It could be you doing your physios while the family members are around. It could be you asking family members to come down. If you are going in the morning to see them, it could be you asking family members to be here because they are likely to, because they are seeing all the stuff as maybe you are trying to harm them. But if the family members are there, that can give them a bit of reassurance, a bit of confidence to be able to engage in physios. So let's think about this thing. Are we having joint section with the family member? It could even be maybe there's this particular nurse on the ward that they've actually been compliant with. They are not compliant with every other staff, but there's this particular lady. They just like this lady and they've been working well. If this lady go to their bedside, give them medication, they're happy to use the medication. Why not you as a physio try to have that joint section with that nurse for them to give them a bit of reassurance? Because we need, because by the time the lady is there, they'll be compliant with your physio. All those kind of things. So it's just about clinical reasonings. What does my patient need? What is actually limiting my patient? And how do I really support my patient as well? All those kind of things. So another limitations I'm going to talk about because of time is anxiety and breathlessness. I'm going to take the two together. Anxiety, ideally it should be separate, anxiety and breathlessness. Because there's a big relationship between these two. That's why I'm taking the two together. Sorry, please, guys. Are we still there? Is it making sense or I'm just...
Yes, sir. Go on. Thank you.
Yes, I'm enjoying the lecture.
All right. Thank you, sir. Thank you very much. So let's talk about anxiety and breathlessness. This is another limitation. Honestly, if we are really going into those poorly environmental in the world, we are going there and we are really trying to move people. Honestly, you're going to meet patients with a lot of anxiety, really very anxious, people that are very, very breathless. So how do we manage these things? These are things, our infrared, those things cannot manage. So how do we manage these people? Now, I'm going to break this thing down because of time. Breathlessness, what does it mean? Breathlessness is not, first of all, let me say this. Breathlessness is not a negative word. Breathlessness is anything, is just breathing sensation that happens to everybody. If you go onto soccer pitch, football pitch, you start running, you start jogging, you start playing football, you're going to feel breathless. It's not a negative thing. And again, breathlessness is just, or you start doing active, like lifting weight or anything, you might feel breathless as well. And I'm sure breathlessness is something that happens to everyone in one way or the other in our lifetime now. So breathlessness is not really a big word. But the other one, this now, is the abnormal time here. The abnormal time. This now part, abnormal breathing sensation. Yeah. But again, what we have to say here, that is, these things are being used interchangeably. Yeah, even myself, when I write now, I put breathlessness. Most time I don't even remember this now. Yeah, that's fine. That's no problem with that. Even evidence-based, go on to different articles. You see these things being used interchangeably. No problem about that. Yeah. So like I said, breathlessness, even sometimes I even use that rationale to engage some of my patients. When they say, yeah, I just work now, I'm really bad. I said to you, to give them reassurance. I just mobilize now, I'm really bad. I say, yeah, it's normal to feel like that. Even myself, if I go to the soccer pitch to play football, I feel breathless as well. Yeah. So it's normal. If anybody goes anything that to challenge their breathing, they're going to feel breathless, which is normal. So no, you are already giving somebody like a kind of reassurance. They will say, yeah, is that, yeah, oh, that's good then. Rather than them being now linking it up because of their acute illness or linking it up because of the study they've had or anything that can even make their breathlessness to get worse. So these are stuff we can actually think about as well. So now, when it comes to mechanisms of breathing or mechanisms of breathlessness, let's quickly talk about that. I'm not going to talk about this anatomy, physiology. Those things are useless. Honestly, they are very useless. So let's just talk about something that is related, something practicable. We can go to the world and try with our patient. Yeah, that's what we want. Not these rudimentary anatomy or something. So now, anytime you challenge your respiratory muscles, your intercostal muscles, diaphragm, all these things, yeah, when you challenge them, yeah, those sensations will move up. They go to the brainstem, I don't even remember them, your pons cerebellum and all those things. I don't even remember those things. They go to your brainstem. From the brainstem, your brainstem is the subconscious part, which is good, yeah, because we know the Appling centers is in the medulla. You might not need to remember that. It's not that. So those things, those are areas where when we breathe, like normally we don't have to think about breathing now, which is good. Otherwise, everybody will be focusing on their breathing right now. We don't have to think about breathing. And from that subconscious part, they go into the cortical part, the cortex, the highest center. Okay, when it gets to the highest center, now why are these things going to the highest center? That thing tells us that we can actually use like voluntary activities, like your conscious actions to actually have impact on our breathing sensation. That is the point I'm trying to bring out from this slide. It's not to come and tell useless anatomy or physiology. Yes, that is not the point, yeah. If that makes sense. And again, together with that, like you also have a lot of things feeding into that conscious center. Let me make this slide more clearer. You also have a lot of things like limbic system. What does limbic system? You don't have to remember that term. Like emotions coming into that conscious center, all these things. What does that mean? Yeah, hippocampus, the blah, 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 those things. You don't have to remember them. So what does that mean? It means that your emotions are also linked with your breathing sensations. The way you feel is going to also affect your breathing sensation. That is the point I'm trying to make. And the second point I want you to remember here is you can also use some conscious activities to challenge somebody's breathing sensation, that abnormal breathing. Because normally breathing is subconscious. Now you can also use some conscious activity to make the breathing sensation better. And again, emotions, anxiety, distress, everything, all those things also impact on people's breathing. That's the point. That's the whole point of this slide. If that makes sense to us. All right. So let me just admit this person. So, all right. So we crack on. So now I'm going to quickly talk about one module here, which is breathing thinking functions. I think some years back, some people developed these things, I think in a Cambridge or something like that. So it's just BTF module. So what does that mean? So now, if my patient is feeling breathless, let's start making it practical now. Somebody is really, really breathless. I want to think about three things in my head. Breathing first. What is causing that breathing? Like the breathing aspect of it means like you are looking like what is driving their breathing sensation, like organic, like is it related with pathology? Yeah, is it from heart issues, or have they got lung issues, or is it like lung volumes, physio related, something you can manage now? Don't forget I told you when it comes to respiratory, you can manage three or four things. You can manage if somebody have got sputum retention, they've got loss of lung volume, they've got respiratory failures or increased work of breathing. Are they my patient that is breathless, that is feeling short of breath, is those things related? Like their breathing sensation, is it related with those things that I mentioned? Or is it related with cardiac issues? Think about that. Yeah, if it is not that, then what else? So think about their thinking part. Thinking part is the psychological part of it. Oh yeah. Is it because now they are anxious? They are really, really very anxious. They are frustrated. They are in stress. They don't even know the uncertainty around their health. Maybe they are thinking that they're going to die. If your patient is thinking, you good. That is why going to in acute hospitals, empathy is quite different from sympathy. Empathy is when you are trying to understand somebody's journey. You are trying to understand somebody's journey, the way you meet them. I'm going to talk about that in a minute. It's different from sympathy. Sympathy is when I'm saying, yes, I'm sorry. Why you say, I'm sorry, it does not really help in acute hospital. Sympathy is not you saying things, like you are truly demonstrating that thing. Demonstrate, and this is the skills that every physios, every healthcare practitioner must have. Empathy, show empathy to people. Empathy, demonstrate that thing. When their family member asking for updates, you should be able to give them that update. That's empathy. Be able to listen to your patient. That's empathy. You are listening. Why are you listening? You are not listening to respond. You are listening to understand. That is empathy. These are good skills that every clinician must have, because you are dealing with humans that have got life like yourself. All right. So thinking part of the cycle. Oh yeah, what is driving that? Is it like they are thinking they're going to die? Is it like they are worried about their family? Is it like they are worried about their health? If they die, what is going to happen to their property, or what is going to happen to their wife? It might even be that is what is driving their sensation. To be able, it is only when you have that conversation. Now, I have screened their blood. I have screened their, I go to the bedside, I escortate, if I need to escortate, I check all of those things. I'm not really worried that this is not. Then what else? Look into the thinking part of the model. Is it anxiety? Is it stress? Anything that is making them feeling the way they are? Then the function part of it is also related. If somebody is been in bed for a long time, they can at rest, they can be really short of breath at rest. They can be really short of breath at rest. Their social context, that is the function part. Their social context, is it coming in place? Yeah. These are some of those things. The people are less very, like they are not being active. They are not being moving around. They are normally independent before. Now in bed, they are not been moving. All of these things can also be making people. So think you are a physio, you're going to be doing the functioning part. Of course, the medical team, They're going to be doing the breathing part. You as a physio, you're going to be doing because you treat people for chest. So you're going to be doing some part of the breathing part. The thinking part is everyone's responsibility. Everyone's responsibility as well. But what is happening to them? Have that conversations with them. All right, because of time, let me just crack on. Now, another thing I would like to talk about now, because before I talk about what we can be doing with people that are anxious or feeling breathless, different sensations. People, now, one thing I'm going to talk about breathlessness here before this sensation is, breathlessness is just that is like a distinct sensation that people can report. People can report different kind of sensations. So when you get to their bed and somebody is saying to you that, like, you can even see they are struggling to talk in full. Their talk is breaking or something. You want to ask them, how is your breathing? How is your breathing? Them, they will say, yeah, man, I'm struggling. They will talk. They will say what is. They will relate to you, right? Then you want to also ask them, what kind of sensations are they having at the moment? Because this thing is subjective. It's subjective. Now, good, we can easily see that somebody is visibly fatigued or visibly short of breath. You can see from their work of breathing and everything, but their sensation is subjective. You want to ask them, just like you're going to ask somebody with like pain. Oh, is he aching? Is he deep? Is he this kind of pain? Ask these people as well. Oh, are they feeling here on that? Usually, evidence base says normally people report 5 things. People will report here hunger. I'm struggling to catch my breath. People will say that to you. Or some people will say, yeah, my chest is tight, chest tightness. This. People will say that. Concentration is also there. Like, people will now start focusing on their breathing. Normally, remember, when we are talking about the mechanism, normally, these are things we shouldn't be thinking about. I'm breathing, I'm not thinking about it. You're also breathing, you're not thinking about it. But now, by the time people now start focusing on their breathing, you know something is happening. How about the hyperventilating part? People can be, if you go to the soccer pitch and start, what are you doing? You're hyperventilating. That is why. Now, listen now, all these sensations here can happen to everyone. You don't necessarily have to be in acute hospital or acutely unwell before you start feeling these things. Now, that was why I mentioned the other time that breathlessness is not like an abnormal term. It's not an abnormal. So it depends on who you are using that thing for, and when you are using that term, and where is the person presenting. For instance, now, if I go on this football pitch, or I go for a run, or I start lifting weight, something like that, I'm challenging my breathing, I'm challenging my muscles and everything. What is going to happen? So I'm going to hyperventilate, which is normal for me. And again, if you bring in BTF model, that BTF stuff, you bring that in here, I'm not going to, that thinking part is not going to affect me. Unlike patients in acute hospital, they don't know what is going to end for them. You don't know what's the outcome, what is going to be the outcome of their health. So some people might be thinking they're going to die. Some people might be thinking they're going to lose their job. Some people might be thinking they are supposed to be in the office making money, all those kind of things. But me, I go on the soccer pitch, I start playing ball. That part, that thinking part of it does not have impact on me. Or maybe what I'm thinking is just enjoying myself, how to go out to score a goal or something. I'm not really worried. I'm not worried about my breathing at that moment. If that makes sense. So breathing sensations here, all these 5, they are not actually abnormal. It depends on who you are using that thing. Or it could be abnormal in your patient context. If that makes sense. All right. Are we still there? Let me just read the chat box. Are we still there? Is it making sense? What do we think? Hello? Oh, it's making sense. It's making sense. Thank you very much. Yeah, thank you. And for those feedback.
It's making sense.
All right. Yeah, thank you. Thank you very much. Thank you very much. Yeah. So the other thing here is the psychology part of it. Now, what I'm saying, if you look at that BTF model again, you cannot believe me now that the functions can impact, patient functions can impact their breathing sensations. Their thinking can impact their breathing sensations, right? Their thinking, it has to do with psychology. Psychology. If people, let's say for instance, now you've got a patient, they've got a really, really bad experience about a particular hospital, and now they are in the, maybe now they just went unconscious and they brought them to the hospital. Now they open their eyes and they suddenly found themselves in the hospital. That their thinking, that their psychology might impact on their health outcome. So there is psychology part to breathing sensation. Now, there is one thing I want us to critically think here. What comes first? Is it the egg that makes the chicken? What comes first between the chicken and the egg? Is it the egg that makes the chicken or the chicken that makes the egg? Don't bring Quranic or biblical stuff here. So what comes first? Is it the egg that brings the chicken or the chicken that makes the egg? Why am I saying these things? Anxiety can cause breathlessness. If you are really, really very anxious, you can start feeling breathless. And if you are really breathless, before you know, you start getting anxious as well. So they both feed into each other. Like it's a kind of, it's like bi-directional kind of things. Anxiety can cause breathlessness can also cause anxiety. If that makes sense for us, good. So now when you go to patient bedside, you might also need to screen. And how do you screen? Is by conversation with your patient, converse with them. This is how you can know if it is tied down to anxiety or if it is tied down to breathing sensations. And again, another thing I need to say here is sometimes if you are working less, especially with old adults, for instance, old lady, now you want to ask them, this their breathing. If they are not old, ask them, is this breathing, is it new? This their sensation, is it new or it's been there for before they come to the hospital? Ask them. If it is old, I don't have to be worried. Don't forget what you are treating acute hospitals as well. It's acute illness. Or you just need to ask them, it is old. Ask them, how have they been coping with that? Somebody have been feeling breathless, maybe because of asthma or anything, organic or COPD or anything, or because of one heart issues for like 20 years ago, and you are come now in the acute hospital. Do you want to treat that? What are you doing? You are not treating that. So the conversation you want to ask with them, because you know their function might have changed now that they are in acute hospital. The conversation you want to ask with them, how are they been coping? How do they go about their day-to-day activity? How does that breathing sensation, did they impact on their day-to-day, on their ADLs, on their instrumental activities if they need to go for outside? These are conversations we need to, because we care for people, physios, we care a lot. We need to be having those conversations. If you go for shopping, if you go to outings, you go for ceremonies, occasions, Nigerian things, how do you cope? So they might say, yeah, I normally have my inhaler my blue inhaler in my bag. Okay, good, fine. You ask them those things. At home, if you need to do your washing, dressing, all those things, cooking, how do you manage? You ask them, how do they cope? This is a conversation you want to. But if it is new, for instance, or again, you want to ask them, the sensation they are currently feeling in the hospital. Don't forget, sensation can be anything. It could be chest tightness, might be short of breath, it might be ventilating. It could be that maybe the one they normally feel at home is maybe chest tightness. Now they are in the hospital, now they're having chest tightness and pain. It could mean something else. Remember, now they are in the hospital, they are now having chest tightness plus pain, and the heart rate is jumping. Yeah, it could be something else. It could be PE. So we need to be able to, we need that clinical reasoning, that nice and sound clinical reasoning. So you need to ask them, oh, is new? Oh, yeah, is it old? Oh, is it new or old? Oh, is it something you normally feel? Are you feeling the way you normally feel at home, or what has changed? Has anything changed? You need to ask them those things. So generally what I want people to, when we go to their bedside, we want to ask them, what kind of breathing sensations are you feeling? You want to even rate how severe is that pain? I can ask patient now, how bad is that your pain on a scale of 1 to 10? Just to have an idea, because these are subjective things. How bad is it? They might say 8, they might say 7, they might, okay. Then what type of sensations? You want to know because you care. And normally, if you are saying it is old, how long does it last? How does it impact your ADLs? All those kind of things. Your family, how do they normally feel? If they are really feeling breathless, how do they feel? Because the way their family are feeling around that can actually impact them. If the family are really anxious, don't forget, anxiety can also make that breathing sensation more. If that is their baseline, do you also want to have that conversation with family as well? Do you want to have that? So all those kind of things, MDTs, the nursing staff on the ward, the doctor, what have they said to you about your breathing sensation? Those conversations are very, very important. So I'm not going to waste time here. So when it comes to management, because of time, how do we manage? How do we manage if our patient is presenting this way in the acute hospital? We know we need to get them out. And again, remember, somebody might have background, like the second case study. I think the third one rather. The lady had background anxiety disorder, panic attack. Now they are in acute hospital, L5, L something, infusion. 15 years ago, they've had physios, they've had MSK physio, they bring to our facility, they are not improving. Now they are in acute hospital and they are breathless. How do you manage them? We need to sit down and design strategies with them. That is what it means. So I cannot go to the ward now and start hitting them with, they've tried that. It does, they are saying it does not help their pain a lot. Is that what I want to repeat in acute hospital as well? No. I know that pain is not my problem. It's not acute. It's not my problem. I know now they can be saying, yeah, pain, but yeah, I need to just, what can we do? How can I make them to tolerate that pain and get them out of the bed and get them out of the hospital as well? Then follow up with whatever thing you want to do, outpatient, and start doing whatever your stuff with them. So we need, because you don't want to delay. Don't forget that last week I spoke about MDT working. You are working with everybody to get patients out of the hospital safely. That's what is very important. You don't want to delay. Day one. And again, don't forget, I mentioned last week, now with all these trainings and everything, we need to start thinking about going on the ward, screen your patient, not putting blame on the doctor that they are not referring patients to you. They are not physios. You should be able to go on the ward, pick those patients, and we start doing our stuff. So we need to know some of these patient limitations and how we manage them. So how do we manage shortness of breath? ICM model. I want to think about ICM model. Break it down. Function part of the BTF, if you remember, body structure and function. What is limiting them? Is it pain? Have they got anything on top of that? There's shortness of breath. Have they got pain on top of that? Pain can also make breathlessness worse, and breathlessness can even make the pain worse. They both feed into each other. What do you want to do pain-wise? We have talked about pain. Yeah, they've got reduced range of motion with it. They've got everything with this. What do you want to do? Do they need equipment to optimize that, their breathing sensation, to be able to sit out of bed? Do they need rotunda? Do they need Sarah steady? Don't forget, I mentioned last time, not everybody can stand to frame. People that cannot stand to frame, then what else are we doing with them? Even with your bastard, not everybody can tolerate that. So somebody that is poorly in bed, now they're having new shortness of breath. They're not eating, not drinking in bed. Do you want to keep them in bed? No, they're going to decondition physically and cognitive wise. They're going to get delirious. What do you want to do? You want to get them out of bed. You want to think about maybe hoist them or something. We need to supporting our patients. So activity limitations. Now that somebody is now breathless or anything, or their baseline or something, check the activities. They're washing, dressing, all those things that I mentioned the other time. Participation. They want to be going to malls. They want to be participating in our environment, go to occasion. What do we want to say to them? What do we want to say to them? All those things. Do they need any adaptations or anything? Personal factor feed into these things as well. Don't forget about thinking. What they are thinking about. Somebody is thinking that they're going to die. Of course, we don't want to go to their bedside and give them false hope. If maybe that is likely going to be what is going to happen to them. We don't want to go there and give them false hope, but we want to still educate them, see how we can emotionally validate them, we can acknowledge their concern at the moment, and jointly see what we can do to facilitate functions. These are not gadgets related. These are just you sitting down with your patient and showing maximum empathy with them. How about BTF model? You can go by this BTF model, breathing, physio-wise. Oh, they've got sputum retention. What do I want to do? I do ACBT, deep breathing exercises. I get them out of bed, get them moving, increase their functional residual capacity, increase their tidal volume, blah, blah, blah. Blast them with cough acid function. That is what I need to do with them. Oh, now those things. I need to use function to optimize their chest. About breathing. Oh yeah, now they are retaining CO2. Do they need NIV? Do they need BAPAP or something? These are physio related. Maybe in future trainings I can talk about all respiratory things and stuff like that. So, feed part, thinking, have that conversation. The function part, physios, do they need equipment? Now they are ready. It could be as simple as maybe somebody is normally independent, working, but they are struggling to mobilize. It could be maybe you just give them frame. Even evidence, there are a lot of evidence around frame. And maybe 4-wheel worker, the one that have seats, that those things can really help managing shortness of breath. When they lean forward, their shoulder guards, everything can relax. Their diaphragm can be in a good advantage to descend and stuff. So, and again, they can easily rest on the 4 wheels. They can even sit on the 4 wheels. All those things. It could be you giving that equipment to them to manage their breathing sensation. And it could be you rehabbing them again, because there's another thing I need to talk about. There's another thing here. Some patient, okay, maybe I just put that to us as questions. If I go to somebody's bedside, you go to a patient bedside and they are really visibly short of breath, and they are saying to you that, and you think if I start working now, that my breathlessness is not going to get worse. What do you want to do? Let me ask the question again. You go to patient bedside, you are negotiating mobility and your stuff with them, and your patient just mentioned to you, they are short of breath at first already. And there is no organic cost to these things. Yeah. Of course, you know that you don't want to keep them in bed. You want to keep doing stuff with them for them to get better. And your patient, these are stuff you're going to see with people. They will say it's live. And your patient just said to you that, oh, I'm short of breath. And so, which is reasonable. By the time they do mobility, you know they will become more short of breath. And your patient just said that to you. What do you want to say back to them? Do we understand the questions? And you've got a patient in bed, they are visibly short of breath at the moment, and they just mentioned to you that. So I don't think I can do that, because by the time I mobilize, by the time I ambulate, my shortness of breath is going to get worse. So what do you want to say to your patient? Hello, guys, are we still there? Hello?
So we are here.
Yeah, all right, sir. Thank you. All right, ma. Yeah, so what can we say to those categories of patients? What can we say? Because the people are going to say things like this to us. You go see a patient, they are short of breath, and now you are negotiating mobility and transfer those things with them. And they just mentioned to you that, I don't think I can do that, because by the time I mobilize, even already their talk is breaking. By the time I mobilize, I'm going to feel more breathless. So what do we want to say to them? Those things must be in our toolbox. Like it must, because you are negotiating this thing with them. So what do we say back to those patients? How do we get them to buy that our treatment we are selling to them? How do we get them to buy that? Or you're gonna just, you don't want to do, that's fine. I go away. Oh, so what have you just done? You keep them in bed, that breathlessness is gonna get worse in bed. So what do we want to do with them? Or we just shout on them, Baba, me, I don't have the time. I have lots of pressure. No, you don't want to do that. Those are old practice. These are unhealthy practice. These are practices that need to be stopped. When people are in the hospital, we need to give them that best respect, that optimum respect, that optimum compassion. We need to show them, not those ones who shout on people. These are bad practices that need to be stopped. So what do we do with that kind of patient? If they are saying, if we mobilize them, they're going to affect their breathing now. So what do we do to them? Yeah, somebody have written PT Drotry. I don't know if I pronounce. I don't know. Sorry. So they've written that educate and reassurance. Yeah. So how do we reassure them? Good stuff, lovely stuff. But how do we reassure this patient? Yeah. How do we reassure them? Because obviously that is what they need. So how do we have that conversations with them? Yeah. Thank you for that. Good one. Brilliant one. Thank you. Yeah. Guys, let's
Hello.
Okay, sir, let me
Good
try
evening.
something. Okay, someone is talking. Let's be.
all right. Go on.
Hello. All right. Good evening.
Yes, sir.
Part of the component or element of evidence-based practice is actual the patient's preference. So as long as we have that understanding, that is part of our ethos and ethics.
Yeah.
That we have to respect our patient's preference.
Yeah.
And so what is open to us is to actually educate the patient about the dynamics of whatever is happening to that patient.
Yeah.
You give education. It's part of our intervention also to give education. For example, now if you look at after template of assessment, what you are asked to ask the patient is how best the patient learn, and you are also asked, you want to watch out for what is the education that the patient needs. So there is also the concept of persuasion.
Yeah.
So you have to, like, in persuading, giving the patient persuasion is when you begin to let the patient know what the condition he has, and this is the dynamics of this condition. This is why I need to give the intervention I'm giving to you now. So it is education and in the context of persuasion that we help us even while we are still respecting the patient preference. Your education make a little of persuasion and making the patient to know why the patient needs to receive the intervention you are giving to the patient. Thank you.
Oh, thank you very much. Lovely stuff. Very, very brilliant stuff. Thank you, Dr. Joshua. That's a very brilliant one. Yeah, I really appreciate that. Yeah. Good one. I love that. Yeah. Somebody was also trying to speak that time. Yeah. I quickly read the chat box. Yeah.
Okay.
You ask them for, yeah, go on.
Okay. I was trying to say that I'll reassure the patient that I'll obviously empathize with the patient by telling the patient that I hear you. And then I'll reassure the patient that we're not going to push too hard. We'll go at the patient's pace. And then maybe start off with helping patient breathe easier first. And then breaking the activities in smaller patterns.
Yeah.
Before we start doing anything. Also, something like a gentle sit-up first. And then if it feels okay, then we'll stand for a few minutes and then we'll progress from there. But I'm not going to leave the patient that properly and say, you're not going. Because sometimes, like you said, some of these things can be psychological also.
Yeah.
Thank you.
Yeah. Oh, brilliant. Impressive. Thank you very much. Yeah, I really personally I'm really enjoying the conversations, honestly. Yeah. Dr. Abubakar has also written, you ask them for reasons why they feel they can't do it. Yeah. Build that, ensure them and start breaking activity into pieces. Wow, brilliant stuff. Yeah. So educate them, reassure them. These are all brilliant stuff. Thank you very much. Thank you for that. Yeah. Just like Dr. Joshua and the second speaker also mentioned. Yeah. Somebody have written something as well. Yeah. Pretty Sharon has also written, you can integrate deep breathing exercises. Good stuff. Yeah. Calm the patient and improving breathing. Yeah, these are stuff we can do with them. Yeah, we're not going to leave them because we know we are good physios. We are lovely people. We care for people. We're not going to leave them. We're not going to run away. We're not going to blast them. And yeah. Oh, yeah. Somebody has also written, explain what I want to do. Yeah. And the benefit. Yeah. These are discussions we can have with them. Loads of things we can do with them. Have that conversation. These are soft skills. These are conversation guided stuff with them. Having that conversation with them. First thing you want to do, understand why, like now they are mentioned to you, which is good. You have to acknowledge that. Acknowledge that reality is a great reality they are mentioned. That because they are likely by the time you mobilize them, their heart rate will go up, their respiratory will go up. So they just even move physiology for you, which is great. So you need to acknowledge that. And now let's have that conversation with them. Now relay back to them the benefit of physios, why we need to be moving. You can even go ahead, tell them about spiral of deconditioning. What does that mean? Spiral of deconditioning. What it means is now what happens with people that normally get short of breath is they try to avoid tax. They do everything to avoid tax and everything. By the time they want to go back to be able to do those things, it's going to become more very, very challenging for them. You want to educate them about that. Because when they are avoiding the tax, they're going to be deconditioned. They're going to lose their muscle mass. They're going to detach muscles, everything, the limb muscles, everything with deconditions. By the time they want to now go back and start doing their daily tasks, it becomes more complex, it becomes more difficult for them. Then educate them. Then try some other things like now. It could be psychological. It could be psychological as well. You want to see if you can cognitively restructure them. All those kind of things. Then again, so that somebody have mentioned deep breathing exercises, you can do those things. Blow as you go, you can do all of those things. By the time you get them out of bed, like sitting edge of bed, try some distractions just to take away their concentrations there, because some people might be concentrating. They are concentrating on their breathing, it's going to make it worse. It might be you now distracting them. Find out what they like. That is when you want to bring in their hobbies and everything, what they like. Talk about those, their hobby. Let them feed you back. Let them talk about their job. Let them talk about their job. It could be people singing. If you like singing, let them. It could be you bring that maybe what do you call it now, MP or this thing to the world. Yeah, play cool music. Let them flow with the rims of music or these things. These are distracting them. It could be you. It could be you doing grinding with them. Grinding. Like look around. What can you see? By the time people start paying attention to the environment, what can you see? What can you hear? What are you? 5 things you can see. But all those kind of things, grinding techniques. You are distracting them away from their breathing sensation. They're going to do better with you. All those kind of things. So understanding our patient impressions, just like Dr. Dusha have said, impressions is very important. Their concerns, what worries them most, is very important. And their expectations to life, to their care, all those things, to their conditions, to their lifestyle, everything. All those things are it really matters to us as a physio. And again, if you do all of these things, let me also say, just like Dr. Joshua had mentioned, because you need to, every care is patient-centered, it's patient-led, not doctor or physio-led, it's patient-led. So if you say all of these things, you try your skills, and they say, no, I'm not feeling up to it. What do you want to do? You're not going to just go away. No, you're going to, well, you respectively have to respect their decision. But you try first. Try have that conversation. And again, before you leave, it might be you saying, okay, yeah, how about if I come maybe later in the day or maybe tomorrow? Because you know that function is what is going to happen. That function is what's going to happen. So what we just need there is just acknowledgement, reassurance, encouragement, emotional validations, getting to use their family, get all those kind of things out. All we just need to help this patient. So let's clap on time. It's going. Thank you very much. Yeah, thank you very much. I really appreciate everyone. Good feedback, good responses, great physios. Yeah. So, and again, shortness of breath is MDT management. Don't forget, we are not working in isolation in acute hospitals. You are working with everybody. That's a doctor. That stubborn guy, that stubborn headed is a poor doctor. He needs physio. He needs physio to be able to do perfect care for his patient. Everyone needs physio. Physio need nurse. Nurse need the doctor. So we need each other. We need exercise physiologists. We need psychologists. We need everyone on the world. And again, you can also use the BTF model as well when with your patient. It could be fun. Sometimes some people, imagine somebody saying, I'm really gasping for here. And again, please, let me say this at this juncture again. I've said it before when I was teaching oxygen. Please careful with the use of oxygen when it comes to patient with breathlessness. Lots of people will say, please, I need oxygen, I'm dying, I need oxygen. If there is no sign of hypoxemia, like dropped in oxygen saturation, you've not got good clinical reasoning to blast your patient with oxygen. What you are doing, if you are doing that, is you are just wasting the hospital resources and you are making our tasks to be more difficult for us. Because now, by the time you start winning the oxygen, I explained the concept of rebound hypoxemia when I was teaching oxygen. So be careful with oxygen, the use of oxygen here. You're going to see a lot of that. We say, yeah, I need oxygen, give me oxygen. Sometimes when I go on the ward, I say, I just go meet the nurse. Please stop blasting these people with oxygen. They don't need oxygen. Or sometimes I just take it off and I look at it, everything is fine. I tell the nurse, monitor, I come back, I check. If they don't need oxygen, there is no good reason why they need to be on oxygen. So shortness of breath is not an indication for oxygen. It is hypoxemia that is an indication for oxygen. I've said this thing, I'm explaining when I was teaching oxygen. You can go back to those videos. They are very important. Good understand. So it could be you educating the doctor. It is not, this is healthcare, this is human being we are treating, very dynamic environment. You might not even reason it in the first place. It could be me just, and I say things in a very respectful way, not me trying to show off. What are you showing off? We are all there to cater for people, to support people's life. That's why we are here. No, it could be again. Now people saying, oh, I need oxygen. It could be you now saying, yeah, oh, let's open the window for fresh air. Let's bring fan, ask family or ward or nurse or somewhere in your store, get them fan the fan. Just to give them that psychology that, yeah, now they have a lot of air that they can breathe in. All those kind of things. And again, where theoretical part, some people have hypothesized, maybe when the fan is blowing, I don't like all these anatomy something. It could be maybe now they stimulate their trigeminal nerve, trigeminal nerve also has some afferent, this thing going to the diaphragm, all this kind of thing. But I don't care about that. But psychologically, what is clear is by the time people, when you just open the window or you just fan them, it could be you just doing that, just fan them, give them that psychological support. Like now we have here to breathe in. All those kind of things. It could be It could be, it could be deep breathing, it could be singing, like I mentioned. If they've got organic, like respiratory support, how do we support them? Treat their chest, depending. I'm not going to talk about those things. Thinking apart, it could be relaxation, it could be CBT. Maybe I just go straight to CBT now. I'll just give us some, because CBT is one of the skills that everyone, irrespective of where you work, at patient facility, acute hospital, we need good understanding about CBTs. CBTs are give skills that everyone in modern age physios must have. Good CBT. Maybe I just go straight to that now after this slide. Function part of it. Do they need equipment? They cannot walk to the toilet without messing everywhere. Do we need equipment for them to protect their dignities, or do we need, or maybe because of their softness, they tend to rush. They might fall. We can give them bedside commode so that they can do this thing on the commode. They can open their bowels there on the commode. It could be maybe advising them about pacing, about all those kind of things, those physio things. How about nutrition? It could be maybe now they are deconditioned, they are not eating well, they are deconditioned. It could be getting that dietitians. Sometimes when let's say somebody step down from critical care, they are globally, they've lost muscle mass, and you want to start rehab. Speak with dietitians. I want to start good rehab with these people. It could be maybe now by the time you see them at your bed, they start feeling breathless. Because now they don't have the reserve, that physiological reserve to do those things. So they need to be feeding well. They need to be feeding well. That dietitian needs to now see how they can support their feeding and eating or something. All those things. Then beyond everything, reassure people. Give them that emotional validation. Educate them about the risk and benefit about it. Because again, you can find people that are really, really very difficult. Really very difficult when it comes to these things. Really very difficult. Despite your education and everything, you keep trying with them. It could be now you can try CBT stuff with them. There's even hem high, motivational intervene skills, all those things. So let's just crack on. There are a lot we can. So because of time, fatigue is also another thing I could have loved to talk about in fatigue. So maybe boom bust cycle. I just quickly talk about boom bust cycle here later with all these things. Boom bust cycle can impact patient with pain, patient with cognitions, patient with fatigue, patient with shortness of breath, patient with anxiety. What a boom bust cycle means? Boom bust cycle is, some people talk about spoon theories and something like that. It's just maybe during the day. Today, my patient is like, boom bust cycle it could be something. Maybe we just educate our patient. We know in the hospital they are short of breath, they are just doing little tasks with us and things like that. We have taught them how to break down their tasks and everything, all those kind of things. It could be we educating them that by the time they get home as well, they want to be aware of this thing. Boom is just on good day. People tend to do a lot of stuff. Blah, blah, let's go for that. Let's go for shopping. Let's go for that. Because of pain, their pain is now less that day. After that day, what happened? Maybe second day, people will now struggle. I'm sure we have seen some of patient disease in this category. After that day, their pain will now go really, really very worse. They won't be able to do 2 days, 3 days. Some people can last as a week or something. We need to be educating people about these things. Educate people. On good day, we want you to do things, but don't overdo it. On your birthday, we don't still want you to stay in bed, because even if your patient is not in the hospital, the greatest treatment you can give to people as a physio is movement. Getting people to be moving, not staying in bed and be blasting them with it. No, it's movement. On birthday, we still want you to be able to do stuff, but we don't want you to be inactive on your bad day. This thing is just good and bad day. Do things on good day, don't overdo it. On birthday, still be doing stuff. I think that's just that about that. So the 3 things about fatigue, I would have loved to spend a lot of time on this, but because of time, planning, pacing, prioritization. Again, fatigue management in acute hospitals, OT-led. Oh, it should be OT-led. OT should have good understanding about fatigue, how you manage fatigue, how you teach people pacing and stuff. Of course, people can also have this conversation as well. But OT stuff. Anyways, let's go. Let me just quickly talk about CBTs now because of time. So when we talk about CBTs is cognitive behavioral therapy. CBTs can be used to manage any of these limitations that we have been talking about: fatigue, anxiety disorders, bipolar, even mental health conditions, bipolar. You're going to see people with background of that in the acute hospital. Background of bipolar syndrome, anxiety disorder, depression, low mood, or people that are currently presenting in that manner. they have low mood, they are not eating, drinking, because they don't know what can hinder them. And we want to go to their bedside to be having discussion with them, to be able to engage them to do stuff. It can be very difficult, really. So again, so CBT is just telling you how people's thoughts, how they think, their thinking, how that can affect their emotions, their feelings, and how their feelings can affect their physical sensation. Physical sensation could be pain, fatigue, shortness of breath. It could even be physiological, these things, blood pressure, heart rate, all those things. I have seen patients before that because of their anxiety, that is what is making their blood pressure to be dropping. And doctors can keep repeating, they keep telling them nothing. They just go to their bedside and start having conversation around CBTs, around how their anxiety can impact their sympathetic responses. And before you know, they start yielding. These are good stuff. It could be you making that big difference. CBT on its own is a big training, but I'll just quickly run through some little things here. So physiological response. So physiological response could be any of those things: pain, shortness of breath, anxiety, could be blood pressure dropping, all those kind of things. And their behavior, people's behavior on the world usually. You might find some people, they overdo things. If people are overdoing, what do you want to say to them? If they overdo things, it's going to impact. Even though we love to work with them, you would love to go to people's bedside and you say, yeah, I'm Sharif, I'm one of the physios. And they say, yeah, I've been waiting for physios. I've been waiting for you. Let's go. Yeah. At the same time, we need to teach how to pay. Spacing is very important. Because with that, if they keep rushing, they can fall. They can overdo things. And by the time they overdo things, what is going to happen to them in the long run? By the time they overdo things, their pain can go worse. Their shortness of breath can go worse. Their fatigue can go worse. If those things happen, they're going to end up not doing anything again, because they have that negative experience. So what can happen is they might not even want to do things after that again. We need to be checking people. So people can be presented with different ways in acute hospital. And aside from that, you can also find people's behavior, people that are just avoiding. They don't want to do things. These are the difficult ones. So you really need to have that conversation. Let's move forward. I'll first of all talk about fear avoidance model here. Fear avoidance. What does that mean? Generally, people have injuries or people are in acute hospital. A lot of things can cause pain, like we have mentioned. Some people, good response. Some people will find a way to go about their pain, their emotional part of pain, their psychological, their anxiety, their physical part of the pain. Yeah, they confront the pain, they go into recovery pathway. Good stuff, perfect. But not everybody will go in that lane. You come to their bedside physio, let's do physio. Yeah, they do physio, they start them, they go home, they are fine, they are resumed back, they have already resumed back to work. That's fine. Not everybody will go into that lane. Some people, injury, they have pain experience. Their pain experience, they will not start catastrophizing their painful pain experience. What does that mean? That catastrophizing pain experience means a lot of things can make that happen. It could be now, they are now thinking because what the doctor have told them, or their past experience about maybe a friend or relative that have had that conditions, that have not survived that conditions. Or it could be maybe their fear, it could be anxiety, it could be low mood. Anything can make them to catastrophize their current situation. Before you know, this kind of people, that they are bringing different negative thoughts into their current condition, before you know what will happen, they will start developing pain-related fear, shortness of breath related fear increasing their shortness of breath, fear increasing their pain. And what does that mean? They will start avoiding tasks on the world, avoidance, hypervigilance. They don't want to do things again. They want to stop doing things. These are people you go on the world, nursing staff will try to give them medication. They say they don't want to use medication. These are people you go as a physio, you want to get them to do so, they don't want to do stuff, they don't want to move. They don't want to move on the world. Okay, and they're not going to stay in the world forever. So now, these are, and if people are not moving, like I mentioned, people lose about 2 to 3% of muscle mass. Physio, that is why we are important. Move people. So now, if they are not moving, they are not this thing, what does that mean? Their physical health will start coming down. They get disuse atrophy, the condition, depression will set in, disability will start setting in. They will die. They're going to die. If it is that, if their physical illness is still ongoing, the acute illness is still going ongoing, they're going to die. That's what it is. So this is just fear avoidance model. So by the time you go to patient further, let's make it practical. Now you go into their bedside, you're having that conversation. You want to find out what is driving what. You see the fear, you see the anxiety, and where is this patient heading to? Are they doing all these things to avoid these things? Think about those things. All right. Now, 2 categories of patients. I've already mentioned these things. 2 categories of patients. One of them You find avoiders, people that don't want to do things, and you find pusher. We call them strider. People that overdo, they overdo things, they overdo a lot. Now, for pusher first, let's talk about pusher. Their thoughts normally, by the time you're having conversation with them, you find things like, yeah, if I don't do it, nobody will do it. I need to do it. Oh, I need to work. Oh, I need to. Yeah, it's good. It could be positive as well, but yeah. All right. So now, feelings. If for any reason these people are not being able to get out of bed, they are not able to do that thing they want to do, they can be anxious, they can be frustrated, they can be in low mood, they can be very, very sad at that moment. And let's say now, behavior, this behavior with you can also find with these people could be, now maybe now they are out of bed, they tend to move too much, they overdo things. These are people, because of pain, they are having abdominal pain from the surgical side, they tend to ask for a lot of pain medications, they tend to get load of pain medication, all those kind of things. You find those behavior in them. And what happened with their physical sensation? Because they are overdoing things, they are overworking their muscles. They're going to have a lot of pain, they're going to have a lot of shortness of breath. They are pushing too much. Their short of breath is going to be, because it has to be graded. That's something might go worse. These are people you find compensatory maladaptive movement. They are overcompensating, trying to avoid that painful part, and they are still pushing. These are people you find. They could be presented in outpatient facilities. And again, you don't want to still stop them not to move. Be careful. Physio, movement is your job. You don't want to stop them not to move. Pacing, teach them pacing, teach them how to calm down. All those kind of things is what you want to tell these people. Now, the avoiders, these are people, the difficult ones. You go to their bedside, they tell you, I can't do it. I don't even know how to start. It's not this thing now. It's not what I'm keen on doing now. All those kind of things. Their feelings, these are people, you normally find them low mood. They are really low mood. They are feeling sad. They are depressed. They don't know. They have a lot of uncertainties about their health. How about their behavior? They don't want to eat. They don't want to drink. They don't want to do physio. They don't want pain medications. They just want to be in bed, be on their own. They don't even want to see their family members. I'm sure we've seen some of these patients before. Physical sensation, what happened? Their pain, big pain. They're going to be in serious pain. Fatigue. They're going to be, some of them will be physically fatigued. Because they are not eating. They have low mood. All those kind of things. These are things you're going to find people doing. Now, how do we manage these people? Before I talk about techniques, it's just breathing. I'm not going into just introducing us to some of these things, not taking it as a topic now. Now, one thing I'm going to say here that is very important is we all need, I know we have been this thing before, we all need to know how to meet our patients. What do I mean by that? If you are going to a patient bedside, and you introduce yourself, and these people are very energetic. Your patient is really, really very energetic. Of course, reciprocate that strength. Oh yeah, hello, I'm Sherif, I'm one of the physicians. Yeah, cool, let's go, let's move. You introduce, you tell them what you have, the plan, what you have, and say, let's go there. Meet them where they are. They are very energetic. Meet them at that particular point, then slowly bring them down. Calm them. Don't rush too much. Don't be enraged. Calm them. And again, at the same time, if you are going to see a patient and your patient is really, really at low mood, they are very depressed at the moment, their mood is really very low, what do you want to do? You meet them where they are. These are patients that you don't want to go to their bed and say, hello, yeah, let's go. You don't have to be that energetic. You are speaking with the wrong patient. Because if you offer them anything, they're going to decline. They're going to say no. Because you do not match their energy level. You do not show that compassion. That is empathy. You are not showing empathy. You have to meet your patient where they are. How about you thinking? This is, you see, what care now, health care generally is now being patient-led. How about you trying to come down to their level? If they are on bed, maybe they are, if you are stand, you don't have to stand. You might need to come down, like come into leaning with them, come to their, what do you call it now? Have a very good eyesight, like eye contact with them, then you can converse. Come to their level. These are people we don't want to be standing and be saying, yeah, today we're gonna give you this medication, we're gonna discharge you, we're gonna bring physio in to move you. For somebody that is in low mood, is that gonna work? No. So those kind of workarounds we are having, we need to think about how, even, we have students with us, we have a lot of staff with us. We need to think about, now that is not the time. when we need to be, we need to bring that energy on board. No, we need to come down to patient level. That is meeting your patient where they are. This is empathy, demonstrating empathy. So all these kind of things. So now, maybe I just quickly join that with, let me say, cognitive restructuring. You know, you are the best side. You are meeting your patient where they are. They are very energetic. You are energetic with them and you bring them down. They are in low mood. You match their energy level. Then you start your conversations with them. Yeah. And what kind of conversation? Because before I talk about cognitive restructuring, because if you don't know, if you don't understand where your patient is coming from, then what conversation do you want to be having with them? So what conversation? So you need to understand their understanding of what is going on. What is their impressions? What do they think is really going on with them? You need to understand that. What is their concern at the moment? What is their greatest concern? What are their worries? You need to understand that. What are their expectations around everything that is going on? You need to understand that part. And again, because why are you listening? And again, like I said, listen to understand, not listen to respond. And again, why they are saying all of those things, you are also reflecting back to them, And I think personally, I feel like these skills is not going to just make you a good physio. It's going to make you a good human being generally. Somebody is coming to meet you with a problem. He's coming to me. Of course, before you start saying anything, try to understand the person, why the person is coming up with that problem. What is their problem, first of all? And you reflect. This is empathy. Reflection is empathy. You are reflecting back to them what they are saying. That you want to also use some phrases that shows that you are listening to them. You are listening well to them. Oh, like maybe this is a difficult journey for you. It's really been a lot for you. One sec. Yeah. So like you've really been through a tough journey. All those kind. Not I am sorry. I'm sorry is not. This is a sympathy word. It does not work. So empathy is something you say and you do at the best side of your patient. All those kind of things. So by the time you understand all these things, then you start. And again, you are listening. By the time you are listening, two things. Yeah, from my experience working with difficult patients on the ward and even in what do you call it, critical care. Two things that I have realized is sometimes when you're having this discussion with patients, two things generally, people can come up with emotions, and the other thing could be logic. Some patients might not even know what is going on, but they will just be speaking about a lot of emotions, something that is not even related with their care. Yeah, flow in that lane. And again, logic. Some patients is just about logic. Logic like, oh, doctor have said, I've got a really bad spine. I've got this thing. Community physio before that I've seen. They have mentioned to me that I've got a very severe degenerative changes. So that is why, by the time, let me say this. Any information we need to pass to patient, we need to make it empathetic. How do you are looking at this spine of a patient, for instance, and I want to communicate to you what I'm seeing on the spine. It is my duty of care again. I do not have to scare you. If it's my duty of care to let you know, this is the scan. Yeah, if you take a spine of 80 years, 70 years, you are getting older. These things are expected. These things, blah, blah, blah. And again, if you even randomly take a scan of the spine of everybody, you are likely to find something on their spine. But again, it might not necessarily mean, something bad is really going on. And just lessen people's problem. It's all about just think about how you can lessen people's problem. Good way you can pass people information and lessen their problem, not worsen. Because whatever you say can make the pain worse. Whatever you tell them can make the pain worse. All those kind of things. So listen to your patient, come to their level, come to their energy, reciprocate whatever they are saying, reflect back to them, and how do you cognitively restructure them. Now you need to tell them your goal, your role, how you fit into their life journey. It's their life journey, it's their journey. Just think about how you are fitting, how you want to fit into their journey. The role you can play in their journey. Now think about those things. If people are having unhealthy belief, how do you cognitively change that thing? How do you cognitively change that thing? People can have negative. People can be stuck in negative experience, negative thoughts. How can you help them out of that for them to be able to do whatever you want to do with them? Behavioral activations. These are some of the stuff people with shortness of breath, people with pain that we can do on the ward. Behavioral activations. It could be now tie that functions to meaningful tasks. Oh, let's go. Let's just walk. Let's just go to the kitchen today. Let's go. That is why in our hospitals, Our hospital need to be constructed in a way that ADLs can be done, and it is physio that can lead into some of these things. OTs can lead into some of these things. Let's have kitchen, hospital kitchen, that we have tasks that we can do tasks. OT can be doing kitchen assessment, toileting assessment, all those kind of things are what we want to be doing on the ward. It could be now you tying that thing to that meaningful activity. Let's just go to the kitchen. Let's go to the kitchen. Let's take let's just go there to take coffee to tea together, whatever it is obtainable where you work, whatever things. It could be you, maybe family members are in maybe where you normally have NDPT meet or where you normally keep family members or anything. It could be you asking patient to walk down to that thing, just to facilitate it to function. It could be you asking nursing staff, like I mentioned last time, rehab is not just when physio comes around or when physio comes to patient bedside. It could be you asking nursing staff to be getting them out of bed. Because now you have trained everybody on the ward to be able to use those equipment, to be able to use rotunda, Sarah steady, all those things. It could be you asking nursing staff to be using that equipment that you have established that it is safe with that particular patient, to be getting them out of bed with that equipment for every meals. Get them out in the morning for their breakfast, when the family brings breakfast, or if the hospital is supplying or whatever thing, depending on where you work. It could be you asking them to get them out in the chair for them to have that conversation with their family member. All those kind of things, tying to functions. Relaxation techniques, all those things, deep breathing, all these tensing, relax, all those relaxation techniques, anything, grinding, music, anything that can relax the patient. Think about those things. Graded approach. Somebody mentioned that for shortness of breath the other time. Today, let's see what we can do today. Don't push them too hard. Don't push them too hard. Oh, let's see today, let's do straight leg raise, seated knee flex, extend, all those things, edge of bed. Maybe tomorrow when I come, I can maybe, because of your shortness of breath, because of pain today, I can just bring bedside chair, you can pivot, or I try rotunda for you to get in. Just break it into simple, like, don't make it too complex for them. And again, it could be you asking them what is their greatest worry, like, in terms of mobility, what is their really greatest? Some patient, when you go to their bedside, they will say to you, my biggest concern with mobility, somebody has mentioned to him that I've got a very, very bad spine. If I come into standing, it's going to be very painful. Oh, what do you want to say to these people? Okay, however, if we try those kind of movements in bed, first of all, let's try knee flexion, knee to chest in bed. Okay, no pain. So we can try sitting now. Break things down for your people. So CBT is really, really a very great skill for us to try. Are we still there, guys? I'm a bit in rush now because of time. Are we still there? Is it making sense?
Yes, it's making sense, sir. Well done, sir. We are enjoying the lecture.
Sorry, sir.
I said we are enjoying the lecture. Thank you so much, sir.
All right, thank you very much. Thank you very much. All those kind of so the real things I'm trying to pass here is beyond gadgets. That's why sometimes when you go on different pages, you see people saying, is it just things? Is it just beyond those things? We do a lot of wonderful things with people. We do a lot, even if you are working in outpatient facilities. If somebody is coming with a chronic pain, it's not my job to be talking about outpatient here. Just have to say this. Somebody is coming with chronic pain. You have been doing blood tests, infrared. It's not improving. You can have that sit-down discussion with them. Try to explore their understanding. Explore what tests can you do. It could be you just doing CBT with them and they will be fine. Honestly, because people believe about their condition. It goes a long way in management. Management now, treatment worldwide now is now tilting towards active, not being passive. Not you being, it is only physio that can do massage. It is only physio that can do no. Treatment is tilting towards active. Tell people what they can be doing. Explore people's belief. It could be those things that can improve. It could even be that as simple as you just having that belief, cognitively restructuring them. Can we even manage that pain? Because chronic pain, again, these are stuff we can be using for chronic pain. Anyway, I'm not going to connect that with chronic pain. Let's just forget about that for now. Sorry. So let's move forward. I'm not going to talk about respiratory. I'm going to have, by God's grace, I will still run some other sessions. I'm going to talk about respiratory care, talk about in acute drugs. I'm going to talk about drugs, talk about different attachment we can have in that, we can see in acute hospital. How do we maneuver them, all those kind of things. But I will just leave those ones out of it. So let's go to, I really would like to talk about this, but I'm just limited with time. Let's talk about documentation. Because now, whatever I do in my notes, if I'm here today, Dr. Shegun must be able to replicate whatever I'm doing. Because these are difficult patients. You are here today, you are doing this with your patient, you have that because all those things must enter into your notes. They need to go into your note. And again, documentation are legal. They are legal documents. Legal documents. So now, because of time, let's get at these things as well. Let's look at these things. Time is gone. I won't be able to talk about this, the legal aspect of the note. I did some job looking into what we've got, what MRTB have got regarding note writings, legal note writings. I've done, and then I've also tried to check globally what we've got regarding legal aspects when it comes to notes. I feel like this is one of the domain again. We need we really need to start taking people accountable for their notes. No, this one is just the patient saying, knee abnormality detected, infrared to the right leg. You just wrote infrared to the, that is what you did to the, what is the patient response? Did they tolerate? What did they say to you? Those things are not coming into those notes. This is an incomplete note, very vague, very, very vague note. Or it could even be in some facility, some very, very senior colleague, by the time they are not even documenting. This is very bad. So we need to start educating our patients, that even medical part of it, like you can charge people to court of law. Yeah, we need to start telling our people because we are responsible for their care. So we need to pay attention to some of these things. So I don't really have time to talk about these things, unfortunately, but I will just skip this. Let's go to, So guys, please, I want us to read through this note. We audit this note, first of all. I want us to read through this note, find out some of those things that are missing in this note. Then we can have a discussion. Whatever you pick that is missing in this note, whatever you pick that you think it should be in this note, so we can raise hand and talk about it. So the first part is, thank you for inviting physios to review a 60-year-old woman admitted due to shortness of breath, pain, weakness of the limb. Past medical histories, hypertension, DM, bilateral OA, COPD, that's the past medical history. The social history is, the lady is 60-year-old, she's a retired civil servant, she does not drink alcohol, does not eat cola. The patient lives upstairs. Observations at their bedside, this physio has written that the patient is met in supine position, fully awake, aware of his environment. The vital signs, this physio have run their vital signs at the bedside. The blood pressure is 130/90, the pulse rate is 92. All right, so head and neck, objective assessment now. Head and neck, knee abnormality, right upper limb, sensation intact, the gross muscle, upper limbs, 5/5, passive active range of motion, full and pain-free, bilateral lower limb, sensation intact, GMP, lower limb, 3/5, active range of motion, full and pain-free, coordination and proprioceptions, everything's intact. All right, sorry, are we following? I really want us to audit this note. Are we following, please?
Yes, sir.
All right, thank you very much. So the analysis, what is physio has written, there is weakness and reduced range of motion at the right upper limb, secondary to stroke, and there is pain at the bilateral lower limb. So the treatment this physio has done, STM to the right upper limb using fastum gel, passive movement exercise to the right upper limb, 5 reps, 2 sets, straight leg raising, 10 reps, bridging exercises ×3, sitting and postural correction re-educations, what program highlighted and emphasized. That is the end of the note. That is what this physio has written. So what do we think about this note, first of all? Good note, bad note, something missing? If you think some things are missing, what are those things that are missing? Let's do this thing together, because note writing is really, really a big thing, and we need to be doing that. So what do we think? So I can just go through that again. 60-year-old woman admitted due to shortness of breath, pain, weaknesses, hypertension, background now, hypertension, DM, OA, COPD, social history, 60-year-old, retired civil servant, does not eat alcohol, cola, they live upstairs, observations, they are in supine, their blood pressure is 135/90, pulse rate 92, head and neck, no deformities, upper limb, sensation is good. GMP 5/5, passive active, full, no concern. Bilateral lower limb, GMP 3/5, active range of motion, full and pain-free, all those things. Analysis, weakness and reduced range of motion at right upper limb due to stroke, pain at bilateral lower limb, and the treatment is there. So what do we think? Because of time, please. What do we think about this note? If you want me to go to any, if you open your mic and you want me to go to any part of the note, I'll surely do that. I'm happy to do that. So what do we think about this note? Open your mic, drop comments in the chat box, yeah? Yeah, people have said a lot of things that I've missed, yeah. Yeah, good, yeah. All right, so what do we think about this note, guys? I really want our contribution here. Of course, we all see patients, we all write notes, and so is it top class notes, top notch, very sound notes, good? Yeah? Hello, who is there? Time is running, please. Hello? Yeah, pop your response in the chat box. Open your mic, speak, let's hear you. What do you think? Do you think something is missing? Do you think it's a very comprehensive note? Yeah? Yeah. Yeah, somebody, yeah, PT Mulikat has written, yeah, no documentation on pain level at the time. Yeah. Yeah, no documentation. Yeah, which shows clearly these physios, if we don't know what he has said to patient about pain, because we know pain can be a barrier here. We don't know what they have said. We don't know what, it's not done anything. It's not written anything about pain. Yeah, that's a good one. Thank you very much. Good contribution, lovely. Yeah. Yeah, no documentation on onset, nature of pain. Yeah, that is also missing. Nothing about pain. Did the person, because if you just go to the base and you ignore, they are saying they have got pain and you are ignoring their pain. What have you not done? You are not showing compassion to them. They are in pain, but did you just ignore their pain? Yeah. No documentation on onset. Yeah. Onset of pain, nature of the pain. Yeah. What else? Omissions of system review like respiratory system, COPD. Yeah, that is also missing from this note. We don't know what is says. We don't know what you have. Yeah, maybe there is a review of their chest or anything. No review about that. Yeah, that is missing. Lovely stuff. Yeah, please keep popping in. Yeah, omissions. Yeah, limited documentations on COPD, shortness of breath. Yeah, it is special because shortness of breath is really a big thing here as well. It's really a big thing for your management. Did you even just ignore their shortness of breath? Did you just ignore that? You've not written anything about their shortness of breath. What have you done? We don't know. If there is a big techniques you've used to manage their treatment, to get them to do stuff, that is not replicable. I cannot go second day now and be able to do that because you've not written it in your notes. Because you've not written. So note writing is all about what you have done that has worked for that patient that day one. I'll be able to go that day to not me now doing my own things the way I want to. Not the third physio come in and do whatever they want with me. There should be treatment carryover. That's one of the reasons why we need to be writing good notes. Not good reasons. Yeah. PT Ericon has written, let me read that out. Nothing on what the patient might have done or who the patient has visited to help before coming to the hospital. Yeah, nothing about that. We don't know about their background, where they're actually coming from. Yeah, even though the physio has provided some social histories, but we don't know if the patient is just coming straight to the hospital or maybe they were previously admitted somewhere before coming. Good stuff. Poor history taking. I really love that. PT Sharon. Yeah, poor history taking, poor assessment of shortness of breath and pain. No functional assessment, no plan for treatment, no analysis of the affected part. Really good stuff. Really good stuff. Yeah, PT Hojo has written no documentation on breathing sounds, poor analysis of findings, no respiratory documentations, no documentations on being seen by other MDC. Good stuff. Before you come around, this patient could have been seen by the doctor. This patient could have been seen by the nursing staff. There's nothing that shows. This not just shows this physio just went to their bedside, do his own stuff and go away. Because you have not shown anything. There is no communication, nothing. You have not shown us what you have picked up from the doctor's note, what you have picked from the nursing note, or what you have, what you have, or what you have, or what you want the nursing staff to be doing with this patient at the best time. You have not written that. No drug histories. Yeah, nothing. It's not written there. No drug histories there. Yeah, thank you, PT Sharon. Yeah, PT Bashir has written no investigation taken. It's not clear from this note. Yeah. Did not assess the reasons for shortness of breath. We don't know if it is respiratory. Remember BTF, if it is respiratory, if they are thinking, we don't know. We don't know. You just go to their bedside, do your stuff, and go. Yeah, somebody has written something here. Let me check. Do not assess their reason for their shortness of breath. Yeah. Location of pain, social history isn't comprehensive. Yeah. We can also pop in what we think are missing in the social histories. Because if you are going to treat patients well, your social history must also be very good. You can also pop that in. Thank you for that. It's not, normal physical activity level, gait, mobility height. It's not written there. Yeah, radiological investigation is written. PT Ojo again. Thank you very much. No, I can find this one now. No lung condition last long. Yeah, good stuff. Brilliant stuff. Very impressive. Yeah. Omission of system review. Yeah. Good stuff. No documentation of onset and duration and conditions. All of these things. Very, very important stuff. Yeah. Keep popping your stuff. Keep popping your this thing. Yeah. A lot of things are really missing in this note. And the reality here is that this note is not reproducible. It's not something I can go second day and start doing it the same way. Yeah, I know from the treatment plan, I can go and I know that it's done things, it's done STM, massage and stuff. Yeah, I know. But what about the conversations part? I don't know how you have been able to maneuver this patient with shortness of breath with everything and you are able to do your stuff. I don't know. Everything should enter your note. Even if the shortness of breath is not something we should be worried about, you should go into your note. You go into your note. No functional assessment. Great stuff. This is Acute Hospital. Remember, tie everything to function. Acute Hospital. Thank you, PT Sharon. You're not doing anything about function. You just went to their bedside, do STM, and you go. Is that what matters to us in Acute Hospital? No. What matters to us is, yes, try see them at your bed. Try get them out of that bed. That is what matters. And that is what, if you are going into MDT second day, this is what you want to be telling the doctor. Yeah, I saw them day one. This is what I did with them. Got them out of bed. They're sitting now. Yeah, this is what matters. Not you leaving them in that bed, doing STM, managing their pain, back pain, this thing. No, even if they are not able, get them at your bed. Even if they are not able to have good sitting balance, after try some sitting balance education. I know the physio has done sitting postural education. Yeah, but it's not. We don't know. What is the patient sitting tolerance? What is patient sitting balance? How are they? Do they tolerate the treatment? We don't know. These things are missing from the note. Yeah, for me, treatment is vague. No progression in terms of ambulation. That's PT Ugozi. Yeah, what happened to sit outside your bed? We don't know. You just sitting postural. We don't know. Maybe it is you just did in bed sitting for them, or you did at the bed. We don't know. Or maybe they sat in chair and you are doing your postural re-education. We don't know. That's a big note. That's really a very big note. Thank you for all the response. Keep popping this thing in here. And again, so let's look at these things. You know this patient came in with shortness of breath and pain and everything. Yeah. What has this patient said to you? Like, this is what you have picked from presenting complaints, or what they told you, or what you picked from the medical notes. But what has this patient said to you? What is their understanding of what is going on? What is the consent? Did you just go to their bedside and you start doing stuff? This is 2026. Treatment is patient-led. Where is the consent? Are they able to give consent? Or do they able to give verbal consent? Or do they just give you non-verbal? They just give you thumb up and say, yeah, crack on, that's fine. I'm happy to have the physio session with you. We don't know. Or is this patient confused? Do they not even have capacity? Do you treat them in the best interest? Believe me, if let's say, for instance, this physio is being asked to come defend this note in the court of law, the likely chance is there that this physio might likely lose their license. However, if this patient just came to the bedside and he start plugging tens in my hand, how does this not cover that? No. Because nothing talks about consent here. Nothing. If you read the note from the top to bottom, everything is all about physio stuff. You are looking at their ops. You are doing your treatment. Nothing patient here. Nothing patient. What has the patient said? Did you get consent? What happened at their bedside? Is their family member present at the bedside? Do you even have a joint section with somebody? We don't know. All these things are missing from the note. You don't know. And the treatment this physio did, and social history, just like I think it is Sharon, social histories that she mentioned, the social history is not very comprehensive. Yeah, retired civil servant, fine, you have mentioned that. How do they mobilize before coming to the hospital? What if this patient is normally bedbound? Do you want to try somebody that is bedbound? Do you want to start? That's their baseline. We don't know. We don't know. Maybe they've got weaknesses somewhere in their limb even before coming to the hospital. How did they mobilize? We don't know. This is not comprehensive social histories. How did they normally get that? Because remember, your social history should be checking patient ADLs. You want to ask them where they live. Do they live alone? Who did they live with? All those kind of things. In their bed, ask them where's their bed. Do they live house, bungalow, or whatever they say they live? Where's their bedroom? All those kind of things. How do they normally get out of bed? Are they fine getting in and out of bed normally? Especially if you are working 60 years old in Nigerian context. Yeah, ask them all of these things. How did they mobilize normally? How did they walk? Are they fine doing their ADLs? What kind of toilet? You need those things. You need to ask them. Let's start doing those things. Not just limiting it to they don't eat cola, they don't drink. No. Ask them ADL, check their bed transfer, and ask them about their bed, ask them about their toilet, ask them about how they normally mobilize, all those things. Ask them how they do their shopping. These are day-to-day life, shopping, all those things. Ask them those things. Ask them those things. Because if somebody, they are normally independent, they do their stuff, now they are in hospital, they might not be able to, by the time they go back home, they might struggle doing those things. Of course, they're going to be eating. And we know we live communal life in Nigeria, fine. Yeah, you need to have that conversation. These are compassion, empathy. By the time they want to start, and by the time we start doing these things, we start checking people's bed transfer and we are documenting appropriately. We start checking how people are going to the toilet when we are documenting. We are checking their ADLs. What are you doing? You are indirectly keying yourself into discharge. Discharge is one of your goals you should be doing in acute hospital. Not doctor they have knee surgery, just send them home. They don't even care if they'll be able to transfer from the toilet. It's physio that need to be doing all these things. Discharge, not them sending you, not you going to the ward and you cannot find your patient again. No. So a lot of things are missing in this note. Consent is not there. We don't know who they have seen the patient with. We don't know if they go alone. We don't know their social history is not complete. All those things. Yeah. And again, what is it again? Let me see. And again, your treatment. I feel like your treatment should actually come. Your analysis will come after your treatment. If you look at SOAP format, your analysis, because your analysis should talk about what you have subjective, what you have picked up from the doctor's note, nursing note, or whatever, or what the patient have said to you, what we have sent for the patient, their understanding, their impression. That's subjective. What is that's subjective? Your objective is your analysis, your treatment you have done. Your objective should be the observation you see at their bedside, your testing or whatever things you see, their hubs and vitals, their blood, everything. All those things should enter into your objective. All right. Then your treatment that you have done should also be under your objective. Then the analysis should now be the summary of your subjective and objective. And your treatment. How do they tolerate? Do they tolerate your treatment? Or are they not able to tolerate it? Are they confused? All those things? Your analysis should now be like a summary. Summarize everything and make a good. See, analysis is not just about impairment. It's not just about impairment. Even if you want to go by ICF model, it's not about just impairment. Personal factor. How does the patient, the personal factor, what did they understand, their motivation? All those things can come under your analysis. Activity limitations, of course, body structure and function. You put your impairment and stuff there, all those things. So analysis will cover how your patient is behaving. Do they tolerate any treatment you have given? All those kind of things will come under your analysis. All right. So let me just go back to the chat box. People are written no indication of actual limb weakness. Yeah, all those things are missing. Physio invited for the. Why is the physio invited for the first time? Yeah, that's another thing. So yeah. So and again, look at the treatment. Look at the treatment. Yeah, this is acute hospital. Yeah, breathing. You've got great. You've done really. This physio has really done great great bed exercises, which is fine. Sitting, but this sitting balance, this sitting and postural correction, you should have just tell us about. Why are you actually doing the sitting balance? Do they have, or the postural re-education, whatever you are doing, do they have poor sitting balance? Those things will come under your analysis. You should be able to justify whatever you are doing for them. Be able to justify that. All right. Yeah, let's move forward. So ideally, because of time, under subjective, of course, we expect our notes to be standard, international standard, SOAP format. So what do we expect in subjective note writing? Tell us about consent. Is the patient able to, did they give you consent? Do they say yes? Are they able to verbalize? Or because there are a lot of people that, like I mentioned the other time, that won't be able to verbalize. It could be maybe they've got, imagine people with head and neck surgeries. Or imagine people, maybe because of their confusion, they are not able to verbalize. You might have to treat them in the best interest. Did you document that? We need to document. So document. So if I'm reading your note and you have written the patient treated in best interest. So in your note, if I'm the second physio, I'm going to see the patient. Oh no, yeah, maybe they are confused. And you put the reason there, treated in best interest due to cognition, or due to confusion on the word, or due to this on the word. So I already know in my head, I'm going to see a confused patient. I need to think about how to support them. That's as simple as that. So put your consent. Of course, your past medical history, social history needs to be comprehensive. Put everything in the social histories. Everything. Check ADLs. Put everything. Beyond eating cola and this thing. Put everything. Social histories. False. Ask them. Elderly patient, 60 years. False. Do you have false in the last 6 to 12 months? Or if you have for what led to divorce? These are things you are helping them to check. Then relevant investigation, like we mentioned, those things are missing from the note. Records of patient wishes, concerns, nothing. What the patient have said to you, patient said this, patient said I'm feeling well, patient said I'm pain. You are not, that thing are missing in that note. It has to be there. When you picked physio, you are not seeing patient, you are not working in isolation. What, even as a doctor, if they are writing their note, they should be putting what they pick from their notes and be putting it in. What they pick from your note, they should be putting it in their note. This is how things work. So let's start doing this. You go to the bedside. What did you read from doctor's note? Put it in your note. As per doctor note, blah, 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 blah. What you pick, document. What you pick from the nursing note. In the nursing note, what are you checking? You are checking how patients are. Nurses will be documenting these things. They need to be documented. We need to educate them to document how patient is doing their washing, dressing, their oral care. Are they independent? Are they needing assistance or family or support from the nursing staff? These are what you are checking. Their confusion, their cognition, because they are staying with the patient. Their cognitions. You need to be checking the nursing note. Their personal hygienes. How are they meeting those things? You need to be checking nursing notes. Before you go in to see them at the bedside, you need to look at the nursing note and tell, because they stay with them 24/7. They need to be, if they are not documenting, it is your responsibility to respectfully ask them to be doing some of this, because now you know those things are impacting your treatment. You don't just go and you do things in isolation. If your patient, they are not meeting personal hygienes on the ward, it is your role as a physio to think about how can you support those patients. From mobility point of view, for transfer point of view, those things need to come in your notes. Pick, and if you pick any of those things from the nursing note, put it in your note. Oh, the review note prior to visit, nursing, this, as per nursing note, put those things in your note. Yeah, if your patient is difficult patient and you are having that highest conversation, then that you are trying to understand their impression, their concern, expect, all those things will come into your note in subjective. What the family member have said to you at the bedside, you have to put it in your note. All those conversation you have with the doctor before coming to the patient. The doctor has said their heart rate is normally labile, they are not metronome. Put it in your note. Or if the doctor has said, yeah, don't worry, I'm not worried with heart rate of 105 at rest for you to do your physio. Put it in your note. It has to go in your note. If the second physio, even from beyond legal point of view, if second physio is coming to see them, you can say, oh yeah, doctor has mentioned this. Or doctor, or you are not to be the quote. The doctor has mentioned to you that, oh yeah, their weight bearing is this, or you pick it from post-op. Put those things concern you. Copy those things. So if you are using or paper this thing, put those things on subjective. No, as per post-operative, no, patient can weight bear, full weight bearing, partial. Put those things here. These are physio. Not just go to their bedside and this and go. No, comprehensive, good notes. Right. How patient is doing. All those things you enter, you ask them, how are you doing? And say, yeah, I'm fine. Some people will say, I'm not feeling okay. Those things should come, the patient conversations will come into your note. Objective, physical assessments, you all know all those physical assessments, all those things will come into your note. They are drowsy, they are looking where they are global weakness, all those things will come under your note. Yeah. Then your treatment under your objective, after you put then what the blood you read. We have discussion about blood. Of course, this is acute hospital. You can't just go and see patients. You have to be checking their HB, you have to check their potassium, you have to be checking their sodium, you have to check their iron, their platelet. We have had discussion about these things. If those things are stable, you can just say, yeah, Hobbs, blood check, all these things are stable. Or if you are worried with anything and you are still cracking on with your physio, for instance, let's say their platelet is, let's say 45, for instance, and you feel like, yeah, they have myelodysplasia, you are not really worried. And doctor has also said, yeah, they are not doing anything active for their patient. They are not populated in future. Document those things. Put it there in your notes. You need to document those things. Because the next physio that will be coming can easily read and comprehend what you have written and know and easily crack on with the treatment plan. Physio is not just, we need to be able to demonstrate that we go to medical school, we have good understanding of patient physiology, and we can correlate and we can write good notes. Those things must come in your notes. Their mobility, how do you, and again, remember acute hospital, like I mentioned, you are not just pain champion. No, you are not certain of pain champion. No, look into your environment and tie everything to functions. You go to their bed, good physio, you have done range of motion, you have done everything, you are doing something in bed. Try sitting edge of bed. How do they get to the edge of bed? Do they need assistance of two to get to the edge of bed? When you get them to the edge of bed, how about their sitting balance? Do they lack a static sitting balance? Or is their sitting balance okay? They are static, they're not. Document those things. This comprehensive notes. Document those things. It has to come in your note. Now, if your patient is they are struggling at the edge of bed when you sat them up, oh, they are now feeling short of breath. Document those. They are short of breath. They are fatigued. You return them back to bed. Document those. How many assistants do they need? Assistants of two. So that if I'm reading your note second day, I will know, oh, I need to grab maybe my junior or my student to come with me to see them because they are needing assistance of two. But if they are documented like that physio has written, we don't know postural education. What's postural education? Very vague. Very, very vague notes. What's postural education? How do you get them to the edge of bed? Is it maximum assistance of one? Do they do it by themselves? It's very vague. These are poor notes. Is it making, guys, are we still here? Are we, or am I just talking to myself? Hello?
Yes.
Yeah, we're here.
All right, thank you very much. Yeah, thank you, guys. Thank you. Yeah, so all those things must enter into your notes. All right, let me just crack on. There's no time to break this thing more down than this. Your analysis, like I mentioned, when you do subjective, you do objective, you do your treatment. The analysis must be summary of the two, not just impairment focus. You are treating human being, not just impairment. What happened to what they have said? What happened to, lot of things can feed and make their pain worse. Lot of things can feed in and make their shortness of breath worse. What are those things that you think is limiting them at the moment? Oh, pain limiting their functions, their sit out of their bed, fatigue limiting that thing, all this beyond range of motion, weakness in the limb, weakness in the strength in the strengthening in the cord. Beyond those things, a lot of things can. It could be cognitions, it could be because they are delirious. All those things will come into your analysis. Analysis is my patient is struggling to tolerate sitting balance. This is a good analysis because of their fatigue. This is not because it could be fatigue. It could be you now think about, let's get a recliner chair. Let's be hosting them to chair regularly for us to progress their fatigue level, to build their sitting tolerance. Think about those things. Write good note. Your note. See, when it comes to write, anything that is not written is not done. Anything if you like, you are the best physio in the world. If you are not written in your note in the court of law, you have not done that thing. Those things must come into your notes. It is not written, it's not done. And again, think about reproducing what you have done. We know you have a good skills. Reproduce that thing. Let your junior can actually go in to be able to do those things. If that makes sense, let me see what people have written in the chat box here. Yeah. All right. Thank you very much. Thank you, guys. Yeah. So let's crack on. So your analysis to just your professional opinion, not beyond function, your opinion, why you think that patient is not progressing. Even prognosis, you can say, and you lose uncertain words. No, this patient will not recover. No, not this patient, not this, because if you are seeing somebody for since day one, you should be able to start thinking, correlate a lot of things, their blood, all the medical team are doing. You can start making your prognosis. Oh, that don't make it look like he's not going to recover. However, if the patient recover, you have make a very poor what do you call it? Poor hypothesis. We don't like that. We don't want, I don't want to read my junior note and start, it does not want. No, use uncertain words. You are not God. The fact that you have read that in your, you have read your patient and you feel like they are not good, but you make it look like uncertain. You can say, oh yeah, this patient is unlikely that, it's likely that this patient might progress. You are saying it's likely. They might not progress as well, they might die. But nobody will take you for that. You can say, oh, it is unlikely. Use those terms. All those times. So those things. So I don't know. I've just sent us this slide so we can read through some of these things. So you can make problem list as well. It depends on, see, it depends. Sometimes I just look at my patient now, like maybe difficult ones. I can use ICF to make my analysis. Sometimes I can just go along the line of just list problem list. Oh, this. The problem is should not just be impairment. See people holistic, not just impairment. And you make your clinical impressions as well. You are not making diagnosis. I'm not the doctor. You shouldn't be fighting this thing with them. Just make your analysis and think about, oh, maybe at the moment, by the time you stand your patient, you feel like, oh, they're having poor standing balance because of their weakness in their leg at the moment. Talk about equipment. Oh, they won't be able to tolerate rotund frame at the moment. So because of their stool posture, we need to try something. Those things will come under your analysis. All those things. So the limitation, the impairment you are making, you should try to tie it to function, because that is what matters to people, to go back to their job, to be able to work. And I mentioned the last time when I was talking about this thing. If you keep fixing on range of motion, how many, even you, physio, that you are going to the world to be treating them, when you are walking, do you really need your hip to come to your chest before you walk? No. You just need maybe 10, 20 degrees in the hip and you are walking, you are mobilizing. Yeah, we know. We want people to have good range of motion in their hip. But tie everything to function. Tie it to functions. All those kind of things. So yeah, because of time. So talk in the analysis, talk about their barriers to therapy. It could be patient limiting, it could be patient factor, like behavior, their behavior that is limiting therapy. Those things should come under your analysis. And how do you think you can overcome that behavior? Or who do you think? Do you need that very senior physios, that our HOD to come around to come and say, document those things? These are patient concerns. Document that. Oh, however, we are liaised with this Dr. Shegun or Dr. Bashir to come around to see. Do those things. Those things should go under your notes. If they are progressing, if you saw them yesterday, and now today you are him, and you feel like they are not progressing well from yesterday, document it in your analysis. Oh, patient is progressing well in therapy. If patient engage well in therapy, progressing well. Today they are able to do sit to stand to frame and take some couple of steps. Yesterday they are progressing from yesterday. Those things to go into your note. You saw them yesterday, you are seeing them today. Well, now, if I read your note and I'm not seeing the progress, no. Then you'll be able to look into, we should be able to write those if they are progressing, if they are at the same level, if they are deteriorating, all those things should enter into our note. All right. So because of time, and when it comes to plan again is, it's not just your next time I want to see them, I will do 10s, I will do 5, I will do sit to stand up. No, it's an avenue to communicate things to MDT as well. They are communicating. And again, in your plan, you want us to know if the treatment is still ongoing, if you are discharging them. Put your discharge planning. Physios, we should start thinking about that. Discharge planning. Our big role, we are not doing discharge. Oh, why you think this patient what equipment do you think they're going to need or something? Document those things. We are documented in analysis. Now document those things. Do they need physio referral follow-up? Do they need patient referral? Document those things in the plan. Even if the doctor are going through your note and they start thinking, for community physiotherapy follow-up, because of this, and you have justified, wow, these people know what they are doing. All those things. And again, if you want nursing staff to be doing something, document, sit them out of bed for all meals, sit them out of bed, encourage independent watching and dressing on the ward. These are ways. Doctor, if you want the doctor to review anything, doctor, please review patient for this, review their blood pressure is dropping during sit to stand, all those things, line standing blood pressure, all those things, document those things. Document those things. So your plan is not just physio related. You are also speaking to the doctor, you are speaking to the nurse, you are speaking to the patient family member, all those things. This physio, that physio is not documented anything. It's not, if you want your juniors to come and do something for them, like maybe your student, for instance, to come and be doing bed exercises with them at some particular time of the day, document that. Let the doctor be able to read your note and say, oh yeah, this is what the physios are planning for this patient. All those things. So let's think about these things. So this is just for that. I'm going to send this slide to us just for that, to further let us understand what we need to be putting in certain domains of our needs. All those kind of things. Now let's look at this second note together. Are we still there, guys? We are rounding off. I'm going to put glycemic as well. Are we still there, please? Hello?
Yes, we are here, sir.
Yes, all right, sir. Thank you. Yeah, thank you very much. Yeah.
Yes, sir, we are listening.
Thank you, sir. Thank you, sir. I appreciate that. Yeah. Let's look at this second note, everybody. Subjective assessment, introduce self and role, verbal consent gave for treatment, joint section with PT, XXXS and Y, senior PT, seen at 10 a.m., family present at bedside throughout assessment, the presenting complaints. Let me just track this one up. The presenting complaint, they are admitted due to shortness of breath, pain, weaknesses, past medical is hypertension, COPD, 480. Don't forget, this is Acute hospital. 480. You do 480, 0. The patient is fine, cognitive wise. Look at social history. 60-year-old retired civil servant, live upstairs, right banisters like banisters and rails. Managing well. They may require assistance of ones from sun on bad days because of their OA flare. That previous CCO didn't write this. Now I understand how OA can impact this lady from their background. They can do this test, but on bad days, on good days, they are fine. They can be running up and down the stairs, but on good days, they normally need their son to support them go upstairs. Their OA gone worse. Now, they have toilet upstairs, shower upstairs. They have no adaptive device in the toilet. That is the fact, like there's no, maybe remember your toileting equipment, your freestanding toilet, your raised seat, raised toilet seat, your mop break. We should be talking about equipment the other time. Or in the wet room, elderly people, there is no chair for them there is no this lady is not got a chair in the wet room, like a shower chair or anything. Now, neighboring, this lady now, she has labor downstairs. That means if the son is not around, we live communal life in Nigeria. If the son is not around, maybe the neighbor can support. Now, this second physio, I've written this thing here. Oh, neighbor live downstairs. Now you can call, if I'm reading this, I can say, yeah, but if the son is not at home, maybe he's travel or something, who is going to help this woman on bad days? Oh, maybe neighbor can help. Something like that. Oh, this patient now, independent, they can do their own wash and dress. Son does the shopping and housework. Now I'm understanding where she's coming from. Oh, she had 2 falls in the last 6 months because of weakness. Normally, she's independent on needed indoors. She can work without any aid and outdoor. She loves local Nigerian music. Now, if you have written this, let's say at some point in this patient care, and this patient really becomes really very poorly, and now she's now having unhelpful health belief. I can think about that local music, that hip hop, or that barista, or that this thing, or that Fuji music that this woman loves. We can go to the best and replicate those things and play to ginger her, to make her look lively. All those things, we need good social histories. They are not just doing social history for doing sake. There might be reasons why there might be needs why we need to just go into those things and we start using those things to optimize our patient care. Now, this physio has also written, review note prior to visit. Oh, patient is now approaching med fit. You see what this physio has written. The previous physio didn't write these things. That now, if I'm the second physio, I read the first note, I don't know if the patient will be discharged that day. I don't know if the patient will be discharged second, but this person have written from the medical note that, oh, this patient is now med. That means now I need to start thinking about discharge. That's why, because I know I should be doing this. I should start preparing for this lady. Now, somebody that has got poor sitting balance in bed, I need to start preparing. Oh, if he goes home, who is going to help? How is he going to cope at home? All those kind of things. Now, this physio has written scan about scan. They've done chest X-rays. No need concern about their shortness of breath. Clinical images are there. They've done everything. I'm just showing all little things. Because of time, let's move forward. spoke with the nursing staff at the bedside. You see, this second physio has written their conversations with nursing staff. So with nursing staff that pay med, they have had to pay medication prior to physio. You can see that. That means this patient was really in pain before I came in. You can see, like this. I feel like the second note is well comprehensive enough. Now I can understand how this patient is presenting, who the physio has spoken with, and all of this. Now, see what the nurse have said to the physio. The patient has not yet sit out. They have not yet sat out in chair, and the lady is really very anxious. The nursing staff have said that to the physio. Now, PT, now you are speaking with the patient now. PT reporting they are unwell, they record pain at the left other limb, and their pain is usual experience at home. You can see. Pain rating is 6/10, numeric rating scale, the reporting sharp pain. This second piece, physio is now talking about patient pain. But the first one, you didn't show empathy. The patient mentioned pain. We don't know what you have said to them. You don't know, maybe you ignore. You don't know, maybe you acknowledge them. We don't know. But the second physio is telling us about their pain now, which makes sense. Now, the second physio continues. Yeah, PT inquiry from patients, like this, you are asking the patient now about their shortness of breath. He's trying to understand patient's shortness of breath. How did this start? What is their breathing sensations? Any chest tightness, chest pain, all those things. This second physio is even asking them to rate their breathing sensations. How bad is it on 1 to 10 scale? Yeah. Look at the second PT now. Patient became emotional, became tearful during conversation. This second physio gave emotional support for the patient. If you are the second physio going in to see this patient, you already know what the patient, how the first section went. You already know that. If you are going in, you are already preparing your mind. Yeah, I'm likely to say this and that to them. Your notes should be very comprehensive, not that vague something. No, PT acknowledge patient concern, reassure them, give men encouragement, talk about focus on goals. Like the second physio is advising them now to focus on their goals because this lady is anxious, she's in pain. You should be able to know how these things can impact your therapy and can impact the patient recovery as a whole. All those kind of things. Yeah. So this second physio, this is really the patient she's really unsure of what is going on. Brief update. The second physio now, the patient is unsure of what is going on. The physio provided update about their about their therapy from their own therapy point of view, and also promised that it's going to help. Patient does not know what is going on, and the physio is saying to them that like physio just provided update where they are here and what they are trying to do with them. And the physio is now saying to them that he's going to speak with the medical team to also provide updates from their own point of view. You see how comprehensive this second one is compared to the first one. This second note shows this second physio is showing compassion. This is compassion and empathy. Somebody is complaining pain. You are empathizing with their journey. This patient is saying to this physio that he does not even know what is going on. Those things are missing in the first note. All right. Yeah, goals and expectations. The second physio discussed that with them. Objective assessment, hubs, alert, 480, met in semifinal, blood, oxygen, they are on oxygen. The second physio didn't even document that. The first physio didn't even document that. Their heart rate, their blood pressure, all those kind of things. Physical assessment, grunts, their cough, they're asking them to cough. All those things are documented in the second physio note, but they are missing in the first physio note. Now, what do you do with them? Deep breathing to relax them because of their shortness of breath and everything. Then look at it. When they did the deep breathing and they do like 3 seconds end inspiratory or something like that, they did that with good techniques. Sit at edge of bed. Now, another thing is, as much as you can, we want to also avoid using, what do you call it now? Abbreviations. We want things to be written in full. Or again, it could be maybe in your department, you people can just have a kind of maybe acceptable abbreviations that every physio model, not you just using abbreviation irrationally. So that if you use anything and I go to the word and I'm struggling, it does not make sense. But there should be some like maybe acceptable abbreviations that we can be using in our department. Standard one, not just, yeah. And again, things like that. And even if if you need to come defend your note in the court of law, your department can easily say, yeah, this is our local policy, this is our guideline, this is what we are using. Something like that. Don't use abbreviations that everybody. And again, you can also extend this to MDT. Sometimes you are reading medical and you are struggling with some certain terminologies. We can lead that. We can lead start. Let's have acceptable range. Let the medical team come up with their own abbreviation. Let us physio come up. So that by the time the medical team are reading my note, they can easily understand this is what this thing means. Something like that. So now this second physio has written, sit at edge of bed, the assistance of 2 to sit them edge of bed. Now the patient performance, good initiation, assistance of 2 to sequence their movement, to get them into upright position, something like that. Yeah, most time, let me also say this. Most people don't like putting this in front of their note. It could come up under your analysis. And if you are the type, like me, I like putting these things there. If you put it, no problem. It's just showing, like, if you're sitting your patient up, how do they behave? You want to bring them from line to sitting. How are they coping? How are they behaving? Do they need assistance? Put those things. Independent sitting balance, they are short of breath. You need get them reassurance. You distract them. You check their blood pressure. This second physio is documenting all of these things. Second physio also did cell lyrics in edge of bed, seated, all those things. Limited end range of motions because of the maybe previous bilateral OE. The second physio is documenting all of these things. So this second physio even tried rotunda. The first physio just did postural education and went away. You should progress the patient. Function is very important. Yeah, this second physio provided information about facilitations, when they stand, their support they are needing, all those kind of things. And this second physio even documented on the mobility board. If you've not got that in your hospital, it might be something you might talk about the management. We need mobility board. Something important that doctor want to pass to them, they can document it. Weight bearing status of people. You are physio, you go to their bedside, you transfer them out of bed, non-weight bearing. Document on the mobility of non-weight bearing, right leg, blah blah blah, pivot transfer, all those kind of things. Document. We need those things. And how did you leave them? This is another thing. So that somebody will now say, yeah, it is physio that killed this person. Did you document that? Do you document? How do you defend yourself in the court of law? You need to document how you left your patient. Yeah, the second physio are documented, left comfy in bed, family at the bedside, table and whatever in their reach, their items in their reach, everything intact. You have documented. And again, who did you speak with after if you speak with anybody, you can document it. Hand over to the nursing staff. Don't forget the second physio has promised that it's going to update the doctor, but there is no doctor on the ward. You're not going to wait for them. All other things to do. Then hand over to the nurse to speak with the doctor. All those things will come in your note. This is a very comprehensive note. Then your analysis, talk about where they are coming from. What is their baseline? Where are they at the moment? Are they off baseline? Are they near their baseline? All those things. Talk about assistance they are needing at the moment. Assistance of 2 to do edge of bed sitting, to sit to stand, all these kind of things. Talk about are they progressing in rehab? This second physio has written a very good note for us. Those things. Are they fixing on the shortness of breath? Do they need reassurance, distraction, validation? And are they eating to that? This is not just function, not just range of motion, SQC, or what do you call range of motion, impairment, or anything. It's not just impairment. You are treating the person as a whole, as a human being. Those things should come under your analysis. Functional weakness. They cannot do this. All those things, their mood. All those things should come under your analysis because of time. So the plan as well. The second physio has written to us, the medical team, to update, because the patient have mentioned that he does not even know what is going on, what the medical teams are trying to do. That is what it could be you. It could be that every time the medical team comes around, they just do their stuff and go. The patient, they do not even give the patient chance to speak. It could be maybe, or patient due to any reason is not speaking. It could be medical reason, it could be psychological, it could be anything. Now they are opening up to you. It could be you now just advocating for your patient. Please, medical team, provide update to the patient. And if there is anything they are saying that you think it is you, physio, that needs to be said, this is avenue for you to document and have that conversation with them. All right, you document those things in your plan. If your treatment is ongoing, you document. If there is pain medication they need to be getting before physio, prior to physio, you document those things there. If you want to continue, now they are struggling with bed mobility, you want to continue bed mobility transfer and everything. You want to continue to stand with them. You want to, what equipment you want to document, their rep, their set. Those things you come in your notes. Then your discharge planning. You come, start doing that. Discharge. What is your plan? Are they going on with crutches? Are they going on with frame? Are they going on with any equipment? Document those things. Are they going on with community physio referral? You should be the one making that decision for your patient. Somebody that is not physio is not telling you to follow patient up with community physio. What a shame. What a shame. So we need to be doing those things. And again, because now it is you going to the work, picking and treating your patient. So we are experts. I should not be waiting for somebody that is not a physio to be telling me to come. I should be able to screen note, read note, and do my good. You can refer patient to me. It is my own discretion to screen the note. You have referred to me to screen the patient note and say, yeah, I'm not going to see this one. They don't need physio. I decline them. If they need physio, you should be able to make that decision. This is the definition of being autonomous. Right. And what do you want the nursing staff to be doing or the family member to be doing with the patient? Rehab is not just when you are there. Or what do you want the patient to be doing on the ward? You document all those things in your plan. If that makes sense, I'm going to stop here today. And then this might be the end of because of time, the end of our I think Physio Essential, by the special grace of God, yeah, I'll still try as much as possible to reach out to the organizers and to our lovely registrars on how we can further arrange some other areas that I feel like we need to talk about. Unfortunately, this is the end of this series. Thank you very much, everyone. Thanks for the opportunity to speak to us. Thanks for your attention. Thanks. I know we are lovely physios and we really care for our patients. So let's keep it up. Let's keep learning. Let's keep doing our beats. I know our government they have chosen to be who they want, but let's try within our own domain to see all we can do to better the life of everyone. Thank you very much. Yeah. So questions. So I'm happy to take questions. I'm happy to if there is any additional to anything, I'm also happy to learn. So I'm happy, guys, before we close the meeting. The organizer, sir.
Hello, sir.
Hello, sir.
Hello, sir. I can hear you. Thank you very much, sir.
Yes, sir. Thanks for having me, sir.
Thank you very much, sir. We really appreciate your time, your expertise. We are very much grateful, sir. So I don't know if there is any comments. So if there's no comments, on behalf of the first, I will start by extending our gratitude to the registrar for giving us the avenue to benefit from you, sir. So, and we have benefited a lot. Let me remind our participants that because there are so many things that happened, some people thought maybe we are just against them or something like that. It wasn't that way. Let me give you an example. This foundation, it has so many activities that it is doing. Like there are so many workshops that is organized by this foundation. I could remember just recently I came back from Abuja. The foundation organized one workshop regarding gait analysis. So if we are given certificates anyhow without scrutiny, then our certificate will not be of any value. So that's why we are creating all these means to make sure that it is only people that are eligible or people that pass our criteria that will be awarded with these certificates. We are not here to oppress or to intimidate anyone. Whatever you see is for the benefit of all of us. We want a situation whereby anybody that present our certificate, people will say, yeah, definitely, it is because you deserve. That's why they give you this certificate. But anyway, that's by the way. We really thank you, our participants, our facilitator, the registrar, the organizing committee. We are very much grateful. We are very, very much grateful. We can't express our joy, but we'll keep on praying for you, sir. So I don't know if there is one or two comments from the participant, or if there's any, maybe something that you think can add value to the workshop that we are organizing, because our facilitator told me that there is another workshop that he is trying to facilitate. So if there's any one of us here that maybe wants to advise us in one or two ways to improve our workshop, so you can raise up your hand. Then we can give you the chance to say your mind. Is there anybody? You can raise up your virtual hand. If you want to say something, you can raise up your virtual hand. So I think there's not anybody. I don't know whether you have something to add, sir. Okay, Amara. Amara is you can unmute and give us, but please just go straight to the point and be precise, please. Amara, you can go ahead.
Good evening, all. Thank you for the workshop and the training. It's really been an eye-opener and a lot of things have been taught. But I was asking, can we have access to the recordings? Because it's something you need to be listening to time and again, so that we don't just learn and forget. At least you can go back to the recordings to remember one or two things. Thank you.
Hello. So that's the essence of the live streaming that we are doing on YouTube. So that whenever you feel like you want to listen to the lecture again, you can just go to the YouTube and watch. Just search for clinical pathway on YouTube. So you will see the series of workshops that are organized by the foundation. Then you can just listen to the one that you wanted to listen.
Oh, okay. Okay. Thank you so much.
Hello, sir. You still there? People's hands are up.
Mr. Okay, you can go ahead. Mr. Okay.
All right, thank you. Thanks, sir. And thanks to Mr. Wagoke for the workshops. Please, can the slides for I think the first, second, and third ones were sent, but I don't think we got the ones for the fourth, fifth, and then this webinar as well.
Yeah. Yeah, surely. Yeah, I will send them over. Yeah, I'm sorry for not sending the previous one. I'm sorry about that. So I'm going to send them by God's grace.
Sorry, sir. Sorry for not asking. I think it is me that no remind you. I'm very sorry.
I actually forgot as well. I'm sorry about that.
Oh, yeah. No problem, sir. So is there any other person? Is there any other one? Sir, I don't know whether if you want to add something.
I think I'm okay I'm okay from my head, yeah. So it's just encouraging us, like, let's just keep learning, so everyone keeps learning yeah. Even myself, I'm joining up I'm like lot of trainings. We are doing fantastic trainings, like bringing, and we need to, like, I just have to appreciate our board, like, yeah. So we've really doing a lot of high yielding training. So I'll just keep encouraging us, look beyond certificates. Let's focus on the knowledge gain and let's just keep learning. That's it. So thank you.
So thank you very much, sir. We are okay. Our academy, you can unmute and make your contribution.
Okay, thank you so much, organizers of this program. We really appreciate this kind of seminar, and then thank you, the resource person. This is a wonderful effort, and you really try. You have done a lot. You have put us through a lot of sessions, and we learned a lot. And it's a wonderful start that they have a plan whereby at any moment you can go online and just rewatch the video, revisit the lecture and everything. Thank you so much. And actually, I just want to add something or suggest some things in respect to the request by one of the organizers in respect to the subsequent seminars that will come up with regard to the certificate issuance. Actually, I'm not against the protocols or the assessment or the way you actually issue out the certificate, but I'm suggesting why you are advertising for the workshops, if you can find a way of maybe stating some of the requirement before a certificate will be gotten. Like you do mention it that for somebody to get a certificate, he must pay the sum of 500 naira to the foundation account. So you can also make it, there are other requirements whereby a person must be paid before he got the certificate. I think those are the things that I want to add. Thank you so much. We look forward to more of this. Thank you so much.
So thank you so much, Dr. Awal Academy. Yes, sometimes there are things that usually come off. You may stop all things, but later new ones can come off. So we'll look into that. Thank you very much for your advice. Mrs. Mulikat Isa Abdullahi, you can unmute and say your contribution, ma.
Okay, thank you so much. I really appreciate this. It's very educative, very insightful. My question, is regarding this. Hello, please, can you hear me? Hello.
Yes.
Yeah, we can hear you. Go ahead.
Go ahead, we can hear you.
Okay. This note taking that you just emphasized on this soap. I want to ask, is it applicable, is applicable in whatever condition the patient presents with? Secondly, these is it both outpatients and both inpatients? This format is generally applicable because here in Nigeria, the truth is that it is not this comprehensive. They don't take notes the way you have just explained it like this, but it's good if we put it into practice. It's really good. It's really going to help in the management of the patient. It's going to give a lot of information. It's going to boost our work here. So I want to know, it's not necessarily in inpatient, both outpatient, it can be adapted, right?
Yeah, thank you very much. Yeah, generally, any patient and contact that physios or any healthcare professional is having with patients, we need to be documenting in the SOAP format. So that is the standard, irrespective of where you work. If you work in community, you work in outpatient, you work in acute hospitals, it has to be SOAP format. That is it. Because it is through the SOAP format, you'll be able to capture everything, anything your patient have said or what you've said to them, who you spoke with, and who was there during your treatment. It is with the SOAP format. And all of these things need to go into our notes. Because you can't tell, you could be, maybe, God forbid, maybe particular patient, they are just worried about what you did to their what you did to them or something. They are not impressed or something like that. Anyone can be sued for medical legal. So it is, and whatever we have done or whatever we have said to the patient, if it is not written, it's not. If it is not done, if it is not written, it's not done. So nobody will take that verbal thing that you have said and like you are coming up with now after you have seen the patient and stuff. So note is really, note is as important as our patient. Like, it's as important as those things that we are doing with our patient. That is what they will tell you in the West. So you really need to do your stuff with patients and sit down with your note and write a very, very comprehensive note. And I also feel like it is something that maybe our lecturer in school or maybe our leaders in the hospital as well, like our senior clinicians in the hospitals. So we need to be taking people responsible for their notes. Like, write good notes that will capture everything. Like, that will really capture, even in the outpatient facilities, good note, good note. When they come to you, they say, yeah, I have pain, I have this. Get those pain histories and document them. What you said to them, all those things will go into the notes. That's it. Thank you. I don't know if I answered the question, ma'am.
Thank you, sir. Perfect. Thank you.
All right. Thank you very much.
So I think in the absence of any comments or contribution, we can end our meeting for today. So thank you very much, sir. We really appreciate your time, your expertise. We are very much grateful, sir. To our participants, you are very wonderful. We really appreciate your patience, understanding, and the support you have been giving us. We hope you will continue to give us such cooperation. Thank you very much. See you next time. Our certificate will be ready hopefully next week by the grace of Almighty. Good night. Bye bye.
Bye bye. Thank you very much. Bye bye. Thank you. Thank you. Bye bye.
Thank you, sir. Bye bye.
Yeah, bye bye. Thank you.
Are you starting the exam now?